Good afternoon to all the panelists as well as all the attendees of today's class. Today we are on day 4 of Paediatric COVID-19 management. We are going to discuss few topics related to COVID. The first topic will be on septic shock, which will be discussed by me, myself, Dr. Neeraj Anand, Assistant Professor in the Department of Paediatrics at KGMU Lucknow. The second topic, which is ARDS and its management, which will be discussed by Dr. Nishant Verma. And the third topic after lunch, that is on MISC, diagnosis and management, that will be discussed by Dr. Ayesha Ahmed from AMU Aligarh. And the fourth topic after that will be on PICU management, general care, hand hygiene, and WAP management, which will be discussed by Dr. Sandhya Chauhan from SRMS Bareilly. And the last topic, handling of disease, will be discussed by Dr. Vineet Singh from GSVM Kanpur. And after that, we will be having a post test. So let's start with our first topic, that is septic shock and its management, which is going to be discussed by me only. There is Mamta team, there is the screen is showing host disabled, participant screen sharing. Kindly allow for screen sharing.
So you can share now.
Okay. Is my screen visible and I am audible?
Yes, sir, your screen is visible and you are audible.
Okay, thank you. So let us start with our today's topic. We are going to discuss about management of septic shock in children. Now, today's learning goal would be, at the end of this class, the participant should be able to recognize that shock in a child, should have a knowledge of different type of shock, and the participant should be able to plan fluid therapy according to different type of shock, and what are the vasopressors and inotropic therapy that we are going to use in patients of shock. So coming on to the definition, by definition, shock is defined as a state of significant systemic reduction in overall blood flow to the tissues, and hence there is failure to deliver adequate oxygen as well as nutrient to meet its need. There is also inefficient removal of byproducts of cellular metabolism. Few more definitions that we should know. Severe sepsis. Severe sepsis is defined as life-threatening organ dysfunction, which is caused by dysregulated host response to infection. Septic shock. Septic shock is defined as sepsis associated with organ dysfunction, including cardiovascular dysfunction. Cardiovascular dysfunction means that the patient is having hypotension and is requiring vasopressor for maintaining blood pressure. Septic shock is basically a subset of sepsis with circulatory and cellular metabolic dysfunction associated with higher risk of mortality. Now coming on to the pathophysiology, in all type of shock, the pathophysiology more or less remains same. There is inadequate perfusion of tissues as well as cells, which leads to cellular hypoxia. Due to cellular hypoxia, there is shift from aerobic metabolism to anaerobic metabolism, which is a less efficient metabolism. And as a byproduct of anaerobic metabolism, there is lactate production, which leads to lactic acid accumulation. So there is energy deficit as well as lactic acid accumulation, leading to metabolic acidosis in these patients. As all the membrane as well as enzymes are pH dependent, so there is cellular membrane dysfunction as well as failure of sodium pump. This leads to intracellular lysosomal release of digestive enzymes. These enzymes are toxic, and as they are released into circulation, they causes capillary endothelial damage. This ultimately leads to destruction, dysfunction, and cellular death. Now, all type of shock goes through basically 3 stages: compensated shock, decompensated shock, and irreversible shock. In the initial phases of compensated shock, there is increase in heart rate and redistribution of blood from less vital organs such as skin as well as GIT to more vital organs such as brain as well as heart. But the blood pressure remains normal in case of compensated shock. When the compensatory mechanism fail, the patient land up into decompensated phase, in which, along with signs and symptoms of decreased organ perfusion, there is also decrease in blood pressure. If the patient is not managed properly at this stage, the patient may ultimately land up into multi-organ dysfunction, ultimately leading to irreversible stage of shock, which ultimately leads to death of the patient. Now, coming on to the different type of shock and their presentation. On the basis of history, if the patient presents with GI losses or hemorrhage, then the patient will be most probably in hypotensive shock due to excessive fluid loss. The patient may be in hypovolemic shock also in cases of third space losses, such as in patients of dengue, or in patients of nephrotic syndrome. In these patients, there is third space loss leading to decrease in effective circulating blood volume. The second type of shock is distributive shock, which include anaphylactic shock, septic shock, or neurogenic shock. In patient of neurogenic shock, there will be history of trauma to brain and spinal cord. In patient of anaphylactic shock, there will be history suggestive of allergy. Septic shock patient will have focus for any sepsis such as pneumonia or UTI. In patients of cardiogenic shock, the patient will have associated signs and symptoms of myocarditis. The patient may have history suggestive of congenital heart disease. In patient of obstructive shock, the patient will have signs and symptoms suggestive of cardiac tamponade, tension pneumothorax, or drug-dependent lesions. Patients of septic shock will have may have presentation of different type of shock. The patient of sepsis may have hypovolemia, either due to third space losses or due to diarrhea or vomiting. The patient of septic shock may have features of distributive shock. Due to abnormal vasomotor tone, there is abnormal vasodilatation leading to peripheral pooling of blood. Or the patient may have signs and symptoms of cardiogenic shock if the patient is having associated myocarditis with them. In patient, all type of shock, the patient in initial phases presents with tachycardia. Initially, there is mild tachycardia, which ultimately progresses to profound tachycardia. So tachycardia is one of the earliest signs of shock, and it is common in all type of shock. The second important feature is tachypnea. Tachypnea is there will be quiet tachypnea in case of hypovolemic shock as well as distributive shock. Quiet tachypnea means that the patient is having tachypnea not associated with increased work of breathing. Whereas in case of cardiogenic shock, the patient will have tachypnea along with increased work of breathing. Tachypnea with increased work of breathing may also be seen in patient of septic shock if the patient is having septic shock associated with pneumonia. Tachypnea with increased work of breathing may also be seen in patients of obstructive shock, in patients of tension pneumothorax. Other features, hypotension. The patient may have hypotension or normal blood pressure in all type of shock, as blood pressure is not required to define a patient of shock. But in case of hypovolemic shock, the patient will have normal pulse pressure. That is the difference between systolic blood pressure and diastolic blood pressure will remain normal. Whereas in case of distributive shock, the patient will have wide pulse pressure with bounding peripheral pulses. This is due to decreased vasomotor tone leading to abnormal vasodilatation. So the diastolic blood pressure is decreased leading to increase in difference between systolic as well as diastolic blood pressure, manifesting as wide pulse pressure and burning peripheral pulses. In patient of cardiogenic shock, the patient will have narrow pulse pressure. There will be delayed capillary refill time, that is, the capillary refill time will be more than 3 seconds in case of hypovolemic shock as well as cardiogenic shock. Whereas in case of distributive shock, if the patient is having warm type of shock, then there will be decrease in capillary refill time, that is known as flash capillary refill. Whereas in distributive shock also, the patient may be in cold shock. In that case, there will be delayed in capillary refill time. In all type of shock, in advanced stages, due to decreased cerebral perfusion, the patient might have altered mental status, oliguria. In patients of hypovolemic shock as well as cardiogenic shock, the patient will have cold extremities. There will be increase in toe-to-core temperature gap. Whereas in case of warm type of distributive shock, there will be warm and flushed extremities. There is favorable response to fluid in case of hypovolemic shock as well as distributive shock. But in case of cardiogenic shock, there could be adverse response to fluid challenge. In case of distributive shock, there will be associated symptomatology. Depending on type of shock, that is, if the patient is having anaphylactic shock, there will be associated features of anaphylaxis. Now coming on to the changes in preload, afterload, and cardiac contractility in different type of shocks. In case of hypovolemic shock, the primary pathology is decrease in effective circulating blood volume due to blood loss or third space losses. So there is decrease in preload. So the primary pathology in hypovolemic shock is decreased preload. There is, to compensate for this decreased preload and to maintain blood perfusion, there is increase in systemic vascular resistance. Due to increase in systemic vascular resistance, there is increase in afterload in these patients. Due to redistribution of blood from peripheries, skin as well as GI tract, there is decreased skin perfusion, leading to increase in capillary refill time in these patients. And mixed venous saturation, which is a marker of decrease, which is a marker of increased oxygen extraction at the tissue level. So there is low mixed venous saturation in hypovolemic shock. Now, in case of cardiogenic shock, the primary pathology is decreased cardiac contractility. Due to decreased cardiac contractility, there is increase in end diastolic volume, leading to increase in preload. Along with that, due to compensatory mechanism, there is increase in vascular resistance, leading to increase in afterload. Capillary refill time will again be increased, and mixed venous saturation will be low. In case of distributive shock, the primary pathology is decrease in vasomotor tone, leading to peripheral vasodilatation, leading to peripheral pooling of blood. So there is decrease in afterload. Along with that, there will be decrease in preload, or the preload may remain normal. The decrease in preload is actually due to peripheral pooling of blood. Cardiac contractility may remain normal, or it may due to compensatory mechanism, it may increase. Capillary refill time will be decreased initially, that is, there will be flash capillary refill initially, but later on the patient may ultimately land up into cold type of shock, that is, there will be increase in capillary refill time later on. Mixed venous saturation is high due to peripheral pooling. There is increased oxygen extraction at the there is increased oxygen delivery at the tissue level. In case of obstructive shock, due to mechanical obstruction to the cardiac contractility, such as seen in case of cardiac tamponade or in case of tension pneumothorax, there is decrease in cardiac contractility. There is increase in preload as well as afterload. Capillary refill time will again be increased, and mixed venous saturation will be low. Now, how to rapidly assess a patient of shock in emergency? For this, we use pediatric assessment triangle. In pediatric assessment triangle, we rapidly look for appearance, breathing, and circulation of the circulation of the skin of the patient. In appearance, we look for signs of decreased decreased organ perfusion. That is, if the patient is having reduced muscle tone, decrease in mental status, weak cry, decreased responsiveness, purposeless or vacant stare, failure of child to recognize or respond to his or her parents, or there is poor response to painful stimuli. In breathing, we have to look whether the patient is having tachypnea, whether the tachypnea is associated with increased work of breathing, or the tachypnea is not associated with increased work of breathing. That is known as effortless tachypnea. So effortless tachypnea is seen in patient of hypovolemic shock as well as distributive shock, whereas increased work of breathing is seen in patients of cardiogenic shock, or if the patient is having septic shock associated with pneumonia, or if the patient is having tension pneumothorax. In that patient, there will be increased work of breathing. We have to look for signs of circulatory failure. That is, the patient is having cold extremities, there is increased toe-to-toe temperature gap, mottled appearance, acrocyanosis, as well as pallor. So these are signs of decreased skin perfusion. Now, clinical recognition. In clinical recognition, we have to look for CRT. If the CRT is increased, that means the patient is having decreased skin perfusion. The patient is having vasoconstriction. It is seen in patients of hypovolemic as well as cardiogenic shock. Flash capillary refill, that is capillary refill time less than 1 second, and flush warm extremities is seen in patients of warm shock. Blood pressure is not required to define a patient of shock. If the patient is having hypotension, that is, the patient has progressed to decompensated stage of shock. Mental status, if the patient is having entire level of consciousness, that means the patient is in advanced stage of shock, and it is an ominous sign. Urine output, which is a marker of reduced internal organ perfusion. So if the patient is having reduced urine output, that is, the patient is progressing to advanced stage of shock. Now, to define hypotension in pediatric patient, we take 5th centile cutoff, blood pressure cutoff, which depend on the age of the patient. For term units, that is for 0 to 28 days, if the blood pressure, systolic blood pressure is less than 60 millimeter of mercury. For 1 month to 12 months of age, if the systolic blood pressure is less than 70 millimeter of mercury. For age group of 1 to 10 years of age, if the blood pressure is less than 70 millimeter of mercury into 2 into age. So if the patient is of 5 years of age, so the blood pressure, if it is falling less, systolic blood pressure is less than 80 millimeter of mercury, that means the patient is in hypotension. If the patient is 10 years and older and blood pressure is less than 90 millimeter of mercury, that means the patient is in hypotension. Not this we have already discussed. We have to look for central as well as peripheral pulses. If we have to look for pulse pressure. In patients of warm shock, the pulse pressure will be wide. That is, there will be increased difference between systolic blood pressure and diastolic blood pressure, and bounding peripheral pulses will be there. In patients of cold shock, there will be normal pulse pressure, whereas in patients of cardiogenic shock, there will be narrow pulse pressure. Decrease peripheral vasoconstriction, decrease intensity of distal pulses compared to central pulses is suggestive of peripheral vasoconstriction and seen in patients of compensated shock. In patient of distributive shock, as we have already discussed, there will be wide peripheral pulses, wide pulse pressure as well as bounding peripheral pulses. Now coming on to the management, general management goal is to increase oxygen delivery to the tissue and decrease the oxygen demand. So to increase oxygen delivery, in all patients, we start with 100% oxygen and titrate according to saturation of the patient. We have to administer fluid according to type of shock that we will be discussing in later in subsequent slides. We have to manage both hypo as well as hyperthermia, as hyperthermia will lead to increase in oxygen demand. We have to correct any metabolic abnormalities. We have to correct any electrolyte abnormalities. We have to correct both hypo as well as hyperglycemia. We have to maintain blood sugar below 180 milligram per deciliter. If the patient is suspected to have septic shock, we have to start antibiotic within 1 hour. If the patient is not responding to fluid therapy alone, we have to start inotropic support. Mechanical ventilation is helpful for decreasing work of breathing as well as causing redistribution of blood. So, as in any emergency case, we have to start with ABC. We have to look for airway, breathing, and circulation. In airway, if the patient is unconscious or GCS is below 8, or if the patient is not able to maintain his airway, we have to intubate the patient. In breathing, we have to start with 100% oxygen and we have to monitor saturation and titrate FiO2 according to the saturation of the patient. In circulation, we have to establish IV access rapidly. If IV access is not achieved within 90 seconds, we should directly go for intraosseous access. We have to regularly monitor for capillary refill time as well as frequent blood pressure monitoring has to be done. Investigations, we should send these investigations in all patients of shock. We have to send ABG to look for PaO2 as well as PCO2. We could also look for lactate level as well as electrolytes in ABG. Blood sugar, we have to maintain, we have to correct any hypo or hyperglycemia. Electrolytes to look for any sodium as well as sodium, potassium or calcium abnormalities. CBC, to look for anemia, thrombocytopenia. PTA, PTT to look for any coagulation defect. Type and cross matching, if we are going to transfuse the patient, we have to do type and cross matching. Cultures, blood cultures, urine cultures, or any specific site cultures as pus cultures may be sent to look for type of organism as well as sensitivity pattern of the organism. So intraosseous access should be attempted in any patient if we could not access IV access within 90 seconds, or if the patient is suspected to if the patient is presenting in cardiac arrest or decompensated shock and vessels are collapsed. Intraosseous access could be can be removed once the venous access is available. The equipment that is required to gain for intraosseous access include alcohol swabs, povidone iodine, 18 gauge needle with trocar, 5 ml syringe, 20 ml syringe, infusion fluids that is to be given, analgesia, anesthesia, and sedation. Local anesthesia may be required in patient if the patient is conscious. Procedure, we have to identify the appropriate site. The appropriate site could be either proximal tibia, distal tibia, or distal femur. In proximal tibia, the site is anteromedial surface 2 to 3 cm below the level tuberosity. In distal tibia, the site is proximal to the medial malleolus, whereas in case of distal femur, it is midline 2 to 3 cm above the external condyle, as we can see in this figure. So it could be distal femur, proximal tibia, or distal tibia. So we have to prepare the skin, initially clean with alcohol, 70% alcohol, followed by povidone iodine, and after that followed by 70% alcohol. At least 5 to 10 centimeter of skin area has to be cleaned. Then we have to insert the needle through the skin, and then by screwing motion perpendicular to the bone and slightly away from the epiphyseal plate, we have to puncture the bone. Once we have entered the bone marrow cavity, there will be feeling of sudden decrease in resistance known as feeling of giveaway. So if there is feeling of giveaway, that means that we have reached the bone marrow cavity. To confirm that we have reached the bone marrow cavity, we could aspirate bone marrow through a 5 ml syringe, or we could directly flush 5 ml normal saline. If there is free flow of normal saline, that means that we have reached the bone marrow cavity. So once we have reached the bone marrow cavity, we have to stabilize the needle, and after stabilization, we could administer fluid boluses by 20 ml syringe manually. So we have to manually give the bolus through 20 ml syringe in intraosseous access. Now for coming on to the fluid management. So for volume expansion, we have to replace both deficit fluid as well as maintenance fluid. In deficit fluid means the fluid which is lost prior to the medical care. So deficit fluid could be either crystalloid fluid or colloid fluid. Crystalloid fluid include ringer lactate, normal saline or half normal saline, whereas colloid fluid include albumin or dextran or hetastarch. Maintenance fluid is given to replace insensible water loss which is lost through skin as well as respiratory tract. It is calculated by Holiday-Sager method. So for initial 10 kg of body weight, we give 100 ml per kg of fluid. For next 10 kg, that is for 10 to 20 kg, we give 50 ml per kg of fluid. And for every kg after 20 kg, we give 20 ml per kg of fluid. So if the patient is 22 kg, for initial 10 kg, we will give 1000 ml. For next 10 kg, we will give 500 ml. And for next 2 kg, we will give 40 ml. So the total daily requirement of fluid for this patient will be 1540 ml. Now, fluid therapy in different type of shock. In patients of hypovolemic shock, we have to administer 20 ml per kg of fluid boluses, which is to be given over 5 to 10 minutes, and that is to be repeated as per requirement as necessary. In special situations such as if the patient is presenting with severe dehydration, in that patient we could give fluid up to 100 ml per kg. This 100 ml per kg of fluid is to be divided into 30 ml per kg and 70 ml per kg as per IMNCI guideline. For age group of more than 1 year, the initial 30 ml per kg of fluid is to be given in 30 minutes, and then next 70 ml per kg of fluid is to be given in 2.5 hours. But in patients of less than 1 year of age, the initial 30 ml per kg of fluid is to be given in 1 hour, and the next 70 ml per kg of fluid is to be given in next 5 hours. If the patient is presenting with hemorrhagic blood loss, in that patient, for every ml of blood loss, 3 ml of fluid is to be replaced. And if the patient is not responding to fluid alone, then PRBC transfusion is to be done in these patients. Albumin may be considered if there is additional IV volume for additional IV volume in patients of shock, trauma, or burn, as albumin acts as a plasma expander. In patients of cardiogenic shock, before giving fluid therapy, we have to assess for any fluid overload. If the patient is having any fluid overload, then we should start with diuretics and vasodilators. But if the patient is having any signs and symptoms of fluid deficit, then we have to give fluid in small liquids of 5 to 10 ml per kg over 10 to 20 minutes. In patients of obstructive shock, we should go for rapid and definitive care, such as in patients of cardiac tamponade, we should have pericardiocentesis, whereas in cases of tension pneumothorax, needle thoracocentesis has to be done for emergency procedure and followed by ICD. The patients of septic shock may have more than one type of shock. The patient of septic shock that we have already discussed may have hypovolemic shock, or the patient may have features of distributed shock as well as cardiogenic shock. In patients of septic shock, we have to administer supplemental oxygen. We have to establish IV or IO access. We have to start fluid boluses with initial 20 ml per kg of fluid boluses of either isotonic saline or colloid. Fluid bolus up to 60 ml per kg could be given until perfusion improves or hepatomegaly develops. So we have to look for any signs of fluid overload. We have to correct any hypoglycemia or hypocalcemia. we have to administer antibiotics within 1 hour in patients of septic shock, and severe lactate monitoring is to be done to look for improvement or deterioration in organ perfusion. In patients of anaphylactic shock, the drug of choice is adrenaline, which is to be given IM, and crystalloid fluids should be given as per requirement of the patient. In patients of neurogenic shock, 20 ml per kg of fluid bolus could be given over 5 to 10 minutes. As in other type of shock, special consideration is to be given in patients of severe acute malnutrition with shock, as the pediatric patients might come with severe acute malnutrition. So, in patients of severe acute malnutrition, we should take care that we should not give any rapid fluid boluses. And the recommendation is that we should give 15 ml per kg of fluid over 1 hour under monitoring. And during monitoring, we should look for any increase in heart rate as well as respiratory rate. If the heart rate is increasing by more than 15 and respiratory rate is increasing by more than 5, then we should stop fluid in these patients. But if there is improvement in heart rate as well as respiratory rate, then we could give additional bolus of 15 ml per kg in next hour. The preferred fluid in patient of SAM is either ringer lactate with 5% dextrose or N/2 saline with 5% dextrose. Now, the amount of fluid that could be given in patient of shock depends on whether we have ICU care available with us or we do not have ICU care available with us. If we have ICU care available with us and we could monitor for signs of fluid overload and signs of adequate perfusion, then in that cases we could give fluid boluses up to 40 to 60 ml per kg, with each fluid bolus of 10 to 20 ml per kg over initial 1 hour. But if we do not have ICU care available with us and the patient is not presenting with hypotension, then we should not give any fluid bolus. But if the patient is presenting with hypotension, then in that case we could give fluid bolus of 10 to 20 ml per kg per bolus. Up to 40 ml per kg of fluid bolus could be given over the initial first hour. But we should stop fluid bolus if there is any signs of fluid overload. Now, what are the monitoring goals that is to be achieved in initial hour as per American Academy of Pediatrics? The central pulses as well as peripheral pulses both should be strong. Distal pulses should be equal to the central pulses. Peripheral skin perfusion, the signs of peripheral skin perfusion, that is the skin should be warm. Capillary refill time should be less than 2 seconds. Mental status, the patient should have normal mental status. Urine output should be more than 1 ml per kg per hour. Blood pressure cutoff we have already discussed in previous slides. Subsequent ICU goals that is to be achieved after 1 hour include normal serum lactate, that is serum lactate should be less than 2 millimole per liter. Target mean arterial pressure should be achieved. We should try to restore and maintain normal perfusion pressure, which is defined as mean arterial pressure minus central venous pressure for the age. Central venous oxygen saturation should be greater than 70%. It is sign of oxygen extraction at the tissue level. Cardiac index should be greater than 3.3, but should be less than 6 liters per minute per meter square. Cardiac index is equal to cardiac output divided by body surface area. Now, if the patient is not responding to fluid therapy alone, then we should go for inotropic support. Before starting any inotropic support, we should ensure that the patient is having adequate fluid therapy and the patient is having adequate volume of adequate circulating volume. The initial choice in septic shock, if the patient is presenting with signs and symptoms of cold shock, include epinephrine. If epinephrine is not available, then we could use dopamine. In patient of warm shock, the preferred agent is a vasopressor like norepinephrine. Vasopressor means that the predominant action of norepinephrine is vasoconstriction. So due to vasoconstriction, it leads to redistribution of blood from peripheries to brain as well as cardiac tissues. Now coming on to the different inotropes that are used. Adrenaline, which is a preferred agent for cold shock. So adrenaline act on all adrenergic receptors. Due to effect over beta 1 receptors, it increases cardiac contractility. So due to increase in cardiac contractility, there is increase in stroke volume. Due to increase in stroke volume, there is increase in cardiac output, leading to increased oxygen delivery to the tissues. Along with that, there is increase in heart rate. So due to increase in heart rate, there is increase in cardiac output, leading to increased oxygen delivery to the tissues. At lower doses, systemic vascular resistance is not increased in a significant amount, so it is beneficial at lower doses. But at higher doses, there is significant increase in systemic vascular resistance, which leads to increase in afterload of the patient, as well as there is increase in myocardial oxygen demand due to significant tachycardia. So both these effects are actually detrimental. So we prefer adrenaline at doses between 0.1 to 0.3 microgram per kg per minute, or you can go up to 0.5 microgram per kg per minute. But doses above 0.3 microgram per kg per minute should be avoided because it increases myocardial oxygen demand as well as increase in afterload. How adrenaline infusion is prepared? Adrenaline ampule contains 1 milligram per ml of ADR. So the amount of ADR is to be used is weight in kg into 0.3. So this much amount in milligram of adrenaline is to be mixed in 50 ml of 5% dextrose or 10% dextrose or normal saline. And when this fluid is run at the rate of 1 ml per hour, it corresponds to 0.1 microgram per kg per minute of infusion rate. Now coming on to the second inotropic support, that is noradrenaline. It is a predominant pressure agent, that is, it causes intense vasoconstriction. Due to intense vasoconstriction, it causes increase in systemic vascular resistance. So both systolic blood pressure as well as diastolic blood pressure increases with noradrenaline, and there is redistribution of blood from peripheries to vital organs such as brain as well as heart. So it is especially helpful in patients of warm shock. It also has some positive inotropic effect, that is, it increases cardiac contractility. It is especially helpful in patients with intrinsic tachycardia. The dose is again 0.05 to 1 microgram per kg per minute. Now, if in patients of cold shock, if ADR is not available, then we could go for dopamine. Dopamine acts on dopaminergic as well as adrenergic receptors. The dose range at doses less than 5 microgram per kg per minute, it activates dopaminergic receptors, leading to increase in cardiac contractility as well as vasodilatation. But vasodilatation is mostly in renal and mesenteric bed. The preferred dose that is to be used in patients of shock include is 5 to 15 microgram per kg per minute. At this dose, the beta 1 effect predominates, leading to increase in cardiac contractility, leading to increase in stroke volume as well as cardiac output. There is also increased heart rate, and due to increased stroke volume and heart rate, there is increase in cardiac output. Both systolic blood pressure, the systolic blood pressure increases, but there is minimal effect on diastolic blood pressure at this dose, at 5 to 15 microgram per kg per minute. But at higher doses, more than 15 microgram per kg per minute, the alpha effect predominates, leading to disproportionate vasoconstriction, leading to increase in afterload. So there is disproportionate vasoconstriction. So although there is increase in blood pressure, both systolic blood pressure as well as diastolic blood pressure at higher doses, but this occurs at the expense of decrease in cardiac output, as there is increase in afterload, and also there is increase in myocardial oxygen consumption. So we prefer dopamine at doses of 5 to 15 microgram per kg per minute. But in few cases, we could go up to 20 microgram per kg per minute. Dopamine basically act on beta 1 receptors, leading to increase in cardiac contractility, leading to increase in stroke volume. So this ultimately leads to increase in cardiac output. Due to effect over beta 2, there is vasodilatation, that is, there is decrease in systemic vascular resistance. This is particularly helpful in patients of cardiogenic shock. It is a good choice drug in situation with poor perfusion and high systemic vascular resistance due to vasoconstriction. So dobutamine may be administered or added to vasopressors in presence of myocardial dysfunction, that is in patients of cardiogenic shock, viral myocarditis, or if the patient is having persistent hypoperfusion despite achieving intravascular volume and adequate mean arterial pressure. The dose is again 5 to 20 microgram per kg per minute. So the dose of ADR as well as NOR-ADR is 0.05 to 1 microgram per kg per minute. Dose of dopamine as well as dobutamine is 5 to 20 microgram per kg per minute. Now, if the patient is not responding to fluid and requiring vasoactive support, in that patient, we could consider stress dose corticosteroid, which is 50 to 100 mg per meter square per dose, followed by 50 mg per meter square divided into 6 hourly doses. If the patient is anemic, that is, if the patient is having hemoglobin of less than 7 gram per deciliter, in that patient, we could consider for PRBC transfusion. If the patient is having deranged coagulation profile, or if the patient is having any active bleeding, or if the patient, we are planning for any surgical or invasive procedure, in that patient, we could consider for fresh frozen plasma transfusion. Prophylactic platelet transfusion should be done only if the patient platelet count is less than 10,000 in absence of any apparent bleeding. If the patient is having any significant risk of bleeding, then platelet transfusion could be done if the platelet counts fall below 20,000. If we are planning for any surgery or any invasive procedure, or if the patient is presenting with any active bleeding, then we could consider platelet transfusion if the platelet count is below 50,000. Blood glucose level should be maintained below 180 milligram per deciliter, and we should also avoid any hypoglycemia. Antibiotics should be administered within 1 hour in patients of septic shock. Diuretics may be used if once the shock has resolved. To resolve any fluid overload, we could use diuretics. Deep vein prophylaxis is not routinely recommended, and we should give prophylaxis to prevent stress ulcers. Early enteral nutrition should be started once the patient is hemodynamically stable. Monitoring could be clinical or biochemical. In clinical monitoring, we should monitor for pulses, CRT, we have already discussed. We should monitor for any for state of hydration. We should monitor for any signs of fluid overload, that is, if there is pedal edema, there is hepatomegaly, increase in JVP, or tachycardia. Pulmonary as well as cardiac auscultation. In fluid overload, there will be fine creps. We should monitor for respiratory pattern, urine output, mental status to look for any signs of internal organ perfusion. Biochemical monitoring, we should monitor for blood glucose level, calcium, lactate, serial lactate level has to be monitored to look for signs of improvement in perfusion, electrolytes, blood urea, nitrogen, and creatinine, as well as liver enzyme to look for any signs of multi-organ dysfunction. CBC as required. Now, take home message from today's lecture is it is important to recognize the patient in initial stages of compensated shock, as it is easier to reward the patients in compensated shock. Fluid therapy is the mainstay for early treatment in case of septic shock and hypovolemic shock. Careful monitoring is to be done, is required to assess for adequacy of fluid therapy and also to assess for any signs of fluid overload. For warm shock, the inotropic support for choice is noradrenaline, And for cold shock, the preferred inotrope is adrenaline. These are my references. Surviving Sepsis Campaign International Guideline for Management of Septic Shock and Sepsis-Associated Organ Dysfunction, and recommendation for hemodynamic monitoring for critically ill child. And thanks for all the contributors of this presentation. That's all from my side. There are no questions, so we directly go to the second lecture, second topic, which will be discussed by Dr. Nishant sir. That is ARDS and its management. So I welcome Nishant sir. What do you say?
Yeah, good afternoon. I hope my screen is visible to all.
Yes, sir. Your screen is visible and your voice is audible, sir.
Is my screen visible?
Yes, sir. Your screen is visible.
Okay. Just a second. Very good afternoon to all of you. I am Dr. Nishant. I will be talking about management of severe COVID and ARDS. ARDS is one of the dreaded complications which can happen in a child who develops COVID pneumonia. The learning goals for the current presentation, which is of around 45 minutes, is to know the definition of pediatric ARDS and definition of severe COVID pneumonia in children, to know how to evaluate these children, what lab investigation needs to be done, knowing the pharmacological treatment of severe COVID pneumonia, what form of respiratory support is needed, indications for mechanical ventilation, and what strategy we have to choose while ventilating a child with ARDS due to COVID. This diagram, many of you must be familiar with. It just shows the clinical course of COVID-19 when it is complicated by ARDS. On x-axis is the time in days, and on y-axis is the severity or infectivity. So this virus has an incubation period of around 5 days, and it is most infectious in the initial days of its illness. So once the incubation period is over, it is at its peak infectivity, and the virus can be infectious even before symptoms happen. So infectivity is maximum here, but symptoms are minimum. The infectivity and the viral load after achieving peak in the initial few days starts to decline. Okay? Although the infectivity declines and the viral load declines, the clinical features tend to worsen by the end of first week. So by the end of first week, there is onset of dyspnea. This is the early phase when the dyspnea starts to develop. Majority of children and adults may not develop any dyspnea. They may just have an upper respiratory tract infection with fever, body ache, and they would recover on their own. But a fraction of this, around 3 to 5% in adults, around 2 to 3% of children may develop dyspnea, and which can further be complicated by ARDS. ARDS happens in the second week of illness. It is the hallmark of inflammatory phase. So the ARDS and the lung damage is caused by release of inflammatory cytokines. It comprises the pulmonary phase of illness. And if a child develops ARDS, he needs higher respiratory support in the form of BiPAP or NIV or invasive mechanical ventilation. And few of the patients may fail even these and may need ECMO for their life support. As the time passes, a fraction of these ARDS patients may recover and get discharged, but majority will have a poor outcome and may die because of ARDS. So how do we define severe COVID in children? So severe COVID is defined as pneumonia with any of the following. A child who is getting cyanosed, his oxygen saturation in the room air is less than 90%, who is having increased respiratory efforts in the form of grunting or severe retractions, or the child with COVID-19 is developing letharginess, somnolence, or seizures. So presence of any of this would be defined as the child has severe COVID. A small proportion of those with severe COVID would also have what is known as critical disease. So critical disease is defined if any one of the following is present: ARDS, shock, or multi-organ dysfunction syndrome. So if any of these three is present, the child would be labeled as critical disease due to COVID. Before we discuss management of severe COVID, we need to know how common is severe COVID in children. It is not that common. In a systematic review of around 7,500 children with confirmed COVID-19, it was found that only 2% developed severe disease, which is in contrast to adults where around 5 to 10% would develop severe disease. So severe disease in this study was defined as those with dyspnea, central cyanosis, or hypoxemia. And of this, only 0.7% had critical disease, which is ARDS or respiratory failure or shock. So children tend to have less serious illness, can be treated just by supportive care, and majority will not need hospital admission, and less so would need ICU care. So that need for ICU in children with COVID is quite uncommon. When do we suspect ARDS? So if a child with COVID is developing progressive tachypnea, is having dyspnea, he is having tachycardia, chest is showing bilateral diffuse crepitations, the child is getting confused, the distress is increasing, he is getting cyanosed, excessive diaphoresis or perspiration is evident. On X-ray, if you can see bilateral infiltrate, again a sign of ARDS, the oxygen saturations are declining, the need for oxygen is rising. So all these are features of which would point that the child is probably developing ARDS. Silent hypoxia, which is commonly seen in adults, is not seen in children. It can be seen in adolescents, but younger children do not have silent hypoxia. They do show signs and symptoms of respiratory distress. Symptoms like cough, chest pain, wheezing, hemoptysis, and fever are inconsistent and may be absent. So if the presence of these is not mandatory to make a diagnosis of ARDS. So for defining ARDS, we need to have certain parameters. So based on this, diagnosis of ARDS and severity classification is made. So these parameters are a chest X-ray, so you must have a chest X-ray. Oxygenation parameters from arterial blood gas, which would include an SpO2 and PaO2. SpO2 you can also get from the pulse oximeter, but ABG also gives you the value of SpO2. Then you need certain parameters from the oxygenation device which you are using, which these parameters are FiO2 and mean airway pressure. So based on these values, you calculate certain indices, and these indices include a PF ratio, which is ratio of PO2 by FiO2, SF ratio, which is ratio of SpO2 upon FiO2, oxygen index, and oxygen saturation index. So oxygen index is FiO2 multiplied by mean airway pressure multiplied by 100 divided by PaO2, and in oxygen saturation index, you change PaO2 to SpO2. So these two values are used to define as well as calculate the severity of ARDS in a given child. So after knowing what values you need to calculate, we come to the definition of ARDS. So for defining ARDS, first thing is to exclude any child with perinatal related lung disease. So it should be an acquired lung disease of acute nature. That is, it should be within 7 days of any known clinical insult, in this case of COVID-19. The edema, origin of edema should be not be explained by cardiac failure or fluid overload. So respiratory failure should not fully be explained by cardiac or fluid overload. On chest X-ray, you should have new infiltrates which are consistent with acute lung parenchymal disease. And once these criteria are satisfied, we need to fulfill the oxygenation criteria. For a child who is on NIV, if he or she is on full phase, bi-level ventilation with a pressure need of more than 5 centimeters of water. And on this pressure, if the PF ratio is less than 300 or SF ratio is less than 264, child would be labeled as ARDS. For the child on invasive mechanical ventilation, we define him as mild, moderate, and severe based on OI of 4 to 8, 8 to 16 or more than 16. Similarly, OSI of 5 to 7.5, 7.5 to 12.3, and above 12.3. So these values are needed to categorize a child as mild, moderate, and severe. Now, over the next few slides, you would come to know that although this definition is not as such important for treating a given patient, but when you want to follow him or her, that is he improving, then you need to calculate these values on a daily basis, and you would come to know that the oxygen index is coming down, which means the child is improving. So for a given patient, the treatment is based on his symptoms, his oxygenation values, and not on the category of severity. It is more for prognostication and for follow-up of a given child. How do we manage severe COVID pneumonia and ARDS in children? First is lab evaluation. As I already told you, that lung damage is because of excessive inflammation. So measuring the inflammatory markers, measuring the degree of inflammation is extremely important. And how do we do that? We do that by looking at the CBC, which tells you the total count, differential count, the hemoglobin values, the platelet counts. Having a baseline liver and kidney function test is also important. And then extremely important are checking the inflammatory markers, which include CRP, D-dimer, ferritin, and procalcitonin. So these inflammatory markers are elevated in a child with COVID pneumonia and COVID ARDS, and their follow-up values would again give you a clue whether the child is improving or deteriorating. Procalcitonin is a marker of bacterial superinfection, so the procalcitonin value suddenly increases multiple folds. It is an indicator that the child probably has developed a secondary bacterial infection. In arterial blood gas, you already have had a class on arterial blood gas. It is very important for any child who is on mechanical ventilation to monitor the oxygenation as well as ventilatory parameters. Doing a chest X-ray would give you a clue of which lung zones are affected and the severity of disease on the X-ray. So these values may need to be repeated every daily or an alternate day, depending on the clinical condition. You may sometimes need to do ABG multiple times in a single day based on the child's ventilatory needs and ventilatory parameters. On X-ray, you can grade the disease severity. Again, you already have had a lecture on interpretation of chest X-ray. So simplest is to, on this chest X-ray, you can draw imaginary lines and you can see how many lung zones are affected. So we can divide the X-ray into 6 zones, and based on the number of zones affected, the disease severity can be categorized as mild, moderate, and severe. If only 1 to 2 zones are affected, it is mild. If 3 to 4 lung zones are affected, it's moderate. If more than 4 zones are affected, it becomes severe radiological disease due to COVID-19. And what typical findings which we get include multifocal, bilateral, and peripheral opacities with rounded morphology, predominantly affecting the lower lung regions. Now, this is an X-ray from one of our patients who was admitted in our COVID ICU last year. You can see that at least 5 lung zones are affected. So this child had a severe radiological disease. So this is the image of that patient. The next imaging modality which is available is an HRCT. Now, what is the importance and what is the role of HRCT? So HRCT is not routinely indicated in severe COVID-19. It does not give you any additional information for which you would have any definitive treatment. So it is not done routinely. Because it is also a difficult investigation to do, it can never be done bedside. Patient would need to be shifted. So for doing a CT, patient must be hemodynamically stable. You cannot shift a patient who is on very high ventilatory setting, a patient who is on HFNC or NIV. These patients cannot be shifted. So patient must be stable on maybe low flow oxygen who can be shifted. So when should we consider doing a CT? CT would be useful when you have high suspicion of COVID, but RT-PCR is negative. So in such scenarios, CTs can provide you a clue that the if CT picture is highly suggestive of COVID, you may need to consider repeating the RT-PCR on another occasion. Sometimes CT is needed when patient is showing an unusual clinical course. He or she is not responding to your treatment. You are finding certain unusual shadows on the X-ray, which may be suggestive of fungal pneumonia. For such cases, CT can be extremely helpful because fungal pneumonia can be diagnosed on a CT, but not easily on a X-ray. The common seating findings of COVID pneumonia include ground glass opacities, consolidation, bilateral peripheral distribution of lesions, and predominantly affecting the lower lobes of the lung. ABG is helpful. It tells you about the oxygen values, SO2, PO2. It also tells you about the PCO2, the ventilatory parameters. Initially, children with severe COVID develop acute respiratory alkalosis because they are hyperventilating. But as the disease progresses, they develop fatigue, respiratory failure, and then develop CO2 retention. So development of CO2 retention, respiratory acidosis is an ominous sign. It indicates the child is probably developing fatigue and now may go into cardiorespiratory arrest. Children can also have metabolic acidosis, which represents presence of sepsis or septic shock or associated AKI or hypoxia. All of them can lead to metabolic acidosis. So clinical monitoring along with serial ABG is important for monitoring these children. So whenever you suspect severe COVID in a child, the first thing you do is you admit that child in your PICU, in your COVID PICU, give that child respiratory support. What supports we'll see. Give drugs like remdesivir and steroids. Consider using empirical antibiotics because at times it is extremely difficult to diagnose bacterial superinfection. Give IV fluids, but don't be overzealous in administration of fluids because excessive fluids can cause pulmonary edema. So restrictive fluid therapy should be used. If a child is going into shock, then you may consider giving a bolus or two, but don't keep on pushing fluids if there is no response to a fluid bolus. You may consider using inotropic support, but always monitor whenever you are administering a fluid bolus. What pharmacological therapy is approved as of now in India? Now, remdesivir is drugs which is approved for children, for adults who are beyond 18 years. In those who are less than 18 years of age, it is currently not recommended by the DGHS, but it has been used at times after taking approval from the Hospital Ethics Committee. But it is not a magic drug. You know, the viral load is not high when the child is in ARDS. Viral load is high in the initial 1 or 2 days of illness. So using remdesivir in the second week may not be very beneficial. So even the recommendations say that it should be used within 10 days of onset of symptoms. Beyond 10 days, it is not recommended. The dose is 5 milligram per kg on day 1, and then half that dose, that is 2.5 mg per kg from day 2 to day 5. For dose above 40 kg, the adult dose of 200 mg on day 1 and 100 mg from day 2 to day 5 is recommended. It is contraindicated if liver enzymes are beyond 5 times the upper limit of normal, or if the creatinine clearance or GFR is less than 30 ml per minute. So beware of checking the liver and kidney function test if you are planning to use remdesivir in a child. Next drug which is used in ARDS or severe COVID pneumonia is steroids. Steroids are very important drugs because they curtail the inflammation. And in COVID pneumonia and ARDS are because of inflammation. So anti-inflammatory therapy with steroids is very important. You can use either dexamethasone or methylprednisolone. Dexamethasone is 0.15 mg per kg per dose twice daily. Maximum dose is 6 mg twice daily. Methylprednisolone 0.5 to 1 mg per kg per dose twice daily. Steroid has to be used for the duration between 5 to 14 days, and the exact duration would depend on your clinical assessment. If you're using it for 14 days, then gradually taper it off over the next 1 to 2 weeks. Antimicrobials, consider using them in children with severe COVID pneumonia because they may have a bacterial superinfection. But don't start with high-end antibiotics like carbapenems, like piperacillin tazobactam. Start with a simple broad-spectrum antibiotics because most of these children are coming from the community. So chances of hospital-acquired infection at onset is extremely less. So use a drug like IV amoxicillin or amoxicillin with clavulanic acid or ceftriaxone. And based on the X-ray changes, based on the procalcitonin values, based on your culture values, you may then escalate your antimicrobials if a child develops ventilator-associated pneumonia or secondary bacterial superinfection. Next is using the respiratory support. What respiratory support is to be provided to these children? The options which are available to you include nasal prongs, a simple face mask, non-rebreathing mask, devices like high-flow nasal oxygen therapy, NIV and CPAP, and invasive mechanical ventilation. So with the help of these devices, we want to achieve a target oxygen saturation of more than 94% during resuscitation. But once the child is stable, anything above 90% is acceptable to us. We can also consider using awake prone positioning, but this should be practiced in older children because younger children at times become very difficult to maintain them in prone position. They may not be comfortable, they may choke on themselves. So you need someone to supervise the child if you are planning to use prone positioning in a younger kid. But in older children above 12 years, you can routinely practice awake prone positioning. Now coming to management of ARDS in COVID, if a child has mild ARDS, you can start with HFNO or NIV. The target saturation is between 92 to 97%. If the child is failing HFNO or NIV, then you will have to intubate and start invasive mechanical ventilation. For moderate to severe ARDS, the target is 88 to 92%. And these patients invariably would need intubation and mechanical ventilation because they would fail NIV and other types of non-invasive oxygen therapy. This diagram shows the stepwise management of hypoxia in COVID. Usually we start with nasal prongs. They are the most comfortable devices. Children tolerate them very well. But the problem is with a nasal prong, you cannot achieve very high FiO2s. You can achieve FiO2 till around 44% if you use a flow of between 1 to 6 liters per minute. So if the oxygen needs are high, you need higher FiO2, then nasal prong will fail. You will have to escalate your oxygen therapy. So the next step is using a plain face mask or a non-rebreathing mask. With a plain face mask at a rate of 5 to 8 liters per minute, you can achieve FiO2 as high as 60%. If you are using a non-rebreathing mask with a flow rate of 10 to 15 liters per minute, you can achieve FiO2 of around 90%. So NRM can provide you higher FiO2s if you are using it at appropriate flow. If the child is not comfortable with NRM, child is having severe respiratory distress, or if his oxygen saturation is not getting maintained on NRM, then you can try NIV or HFNC. So HFNC has it's a high flow device because you have high flow of oxygen in this device. And NIV is a positive pressure ventilation without intubation. So they can be tried. HFNC is typically more comfortable to children. NIV for the long periods, it becomes difficult. Children do not tolerate it well if you are using it and using NIV for long periods of time. And for both of them, for HFNC as well as NIV, child should be conscious. If the child is unconscious, then he's at very high risk of developing airway failure, airway collapse. He may not be able to maintain his airway, he may aspirate. So such patients, it is always preferable to intubate and mechanically ventilate. So endotracheal intubation, if there is no improvement on NIV or HFNC, would be the last resort. Now coming to indications of intubation and mechanical ventilation in severe COVID, a child who is having severe respiratory distress and is developing exhaustion or is going into respiratory failure, then you should consider intubation. If the child's sensorium is deteriorating, his GCS is below 8, then he is at a risk of airway collapse, airway aspirating his or her secretions, then such a child should also be intubated. The child who is having hypoxia, saturation of below 85% despite use of NIV or BiPAP or HFNC or NRM, then again you should consider intubating. Any child with severe ARDS should be intubated. The child who is having CO2 retention, because none of these oxygenation devices would help in CO2 removal. Apart from NIV, which to an extent helps in CO2 removal, NIV and BiPAP, HFNC, face mask, NRM, they do not help in CO2 removal. So if a child is developing respiratory acidosis, CO2 retention, then you should consider intubating and mechanically ventilating. Coming to mechanical ventilation. So I would, in next 2-3 slides, I would try to revise whatever was taught to you yesterday on basics of mechanical ventilation. So whenever you are ventilating a child, you have to choose the mode first. So there are two broad types of mode, pressure and volume. So these are the control variables. So whatever control variable you choose, that decides in which form the breath would be delivered. So you can choose either pressure or volume modes. Both of them have their own advantages and disadvantages. Whichever mode you are comfortable with, use that control variable. So either pressure or volume. After choosing the control variable, you choose the phase variable. So phase variable means in what way the breath would be fine-tuned. So in other words, when should the breath start? When should it reach the limit? When should it end? And what is the baseline variable? So these are the 4 phase variables. So this is the trigger A. When should the breath start? That is trigger. Limit, till what duration the breath, positive breath should continue. That is the limit. And cycling, when should breath start, cycle from inspiration to expiration, that is cycling. And baseline is what baseline parameter should be maintained. This is usually the positive and expiratory pressure, which is the baseline value, which is maintained throughout your respiration. Once you have chosen your control variable, pressure or volume, you choose your mode. So mode, we typically in a child with ARDS, we begin with either SIMV mode or assist control mode. Now, what is the difference between SIMV and assist control? In SIMV, this is on this lower diagram is the SIMV mode, and you can see that these values, so whenever the value, this is a scalar plot, on x-axis is time and on y-axis is pressure. So this is a pressure scalar, and you can see whenever the pressure is going down, this means the patient is breathing. So this is a patient is breathing, and patient is breathing. So although the patient is breathing, you can see 5 times here, but ventilator is delivering breath only twice. So this is the ventilator got triggered, and this is when the ventilator got triggered. The remaining 3 times the ventilator did not trigger. This is because ventilator would trigger only number of times you set the respiratory rate. So if you have set a respiratory rate of say 20 per minute, then 20 times the ventilator would deliver a mandatory breath. So whenever a patient triggers, even if the patient is triggering 60 times, it would deliver only 20 mandatory breaths. The remaining 40 would be patient's own breaths, which are not supported, and patient would be forced to breathe on her or on his own. On the other hand, in assist control mode, so you can see again 6 triggers, and all the time a patient triggers, ventilator takes over and gives a mandatory breath. So even though if you set a rate of 20, patient is breathing at a rate of 60, then in assist control mode, all 60 breaths would be controlled by the ventilator. While in SIMV, only 20 breaths would be controlled. The remaining 40 breaths, patient will be taking on his own. They would not be supported by the ventilator. They will not be supported by the ventilator. So the advantage of assist control mode is the work of breathing would be reduced to a great extent. So jab patient shock mein hoga, you want his work of breathing to be quite low. So for such patients, assist control mode is always preferred. For the patient with ARDS, again, you want the work of breathing to be reduced. So assist control mode can be used. But what is the disadvantage of this? A patient with raised intracranial pressure who is hyperventilating because of increased intracranial pressure, अगर उसको हम assist control mode पे ले लेंगे, तो हर breath ventilator control कर लेगा. So इससे CO2 washout बहुत ज़्यादा हो जाएगा, more than what you want. So for such patients, assist control mode is not a good mode. So patients who are hyperventilating, maybe because of metabolic acidosis, because of raised intracranial pressure, for them, assist control mode is not good. But for patients with ARDS, patients with septic shock, assist control mode is a good mode of mechanical ventilation. There is another mode, the SIMV plus pressure support. This mode is very popularly used in our PICUs. It is available in the Jagger mechanical ventilator, which is available with us. Now, in this, what advantage over plain SIMV is that there is a pressure support mode. So, जो 40 breaths patients खुद से ले रहा था, उनको हम छोड़ेंगे नहीं. So in this case, we have left all these spontaneous breaths. What SIMV plus pressure support does is it supports those spontaneous breaths. Yes, spontaneous breath ko bhi ventilator is going to support. So all the spontaneous breaths which are beyond the set rate would be supported by the mechanical ventilation. They will not be controlled, but they would be supported. जब inspire करेगा patient, so एक pressure support जो आप set करेंगे 8, 10, 12, whatever you set, it would be supported and patient's work of breathing would be reduced. So SIMV plus pressure support is also an excellent mode and can be used as a first choice mode for a child with ARDS or septic shock. There is another mode which is CPAP plus pressure support. Now this is a spontaneous mode. Spontaneous mode. It should be used for weaning. It should never be used as the initial mode. Patient जब ARDS में है, आप start कर रहे हैं patient को ventilate करना, don't use this mode. This is a weaning mode. Work of breathing is not going to reduce. Patient has to do everything on his own. Only a small support is provided by the ventilator during his inspirations. It's not going to control the patient's respiratory effort. पेशेंट अगर स्पॉन्टेनियस ब्रीथ ही नहीं कर रहा है, CPAP प्लस PSV विल फेल, कुछ भी नहीं सपोर्ट करेगा, वो बैकअप में चला जाएगा जो आपने अपनिया बैकअप सेट किया. So it should be used only for a spontaneously breathing patient who is planned to be extubated or who is on mechanical ventilation for some other reason, not the initial mode for ARDS. So after deciding your mode, you set the initial parameters. So what parameters you have to set? First was mode, we already discussed. You can use either pressure or volume, SIMV or assist control, whichever you are more familiar with, more comfortable with. Next is setting the tidal volume. So if you use the volume mode, you'll have to set tidal volume. If you choose pressure mode, you'll have to set PIP. So अगर आप volume mode set कर रहे हैं, then in a child with ARDS, you always start with low tidal volume, that is 6 ml per kg. If you are starting with pressure mode, then start with a PIP of 20 to 22 centimeters of water. PEEP, you have to keep it, start with a bit higher PEEP, a PEEP of between 8 to 10 centimeters of water. And based on your saturation values which you get, you will have to titrate your PEEP further up to achieve the target saturations. FiO2, you start with a FiO2 of 100%, and once the target SpO2 is achieved, you gradually reduce the FiO2. Don't keep the FiO2 at 100% always, because आप कभी patient को extubate नहीं कर पाएंगे. You have to think about the long-term goal of extubating the patient. So जैसे ही आपका target saturation achieve हो, start reducing the FiO2. Set the respiratory rate physiological as per the child's age. So for a 1-year-old, you'll set the respiratory rate of around 30. For a child who is, say, 10 years of old, you'd set the respiratory rate of between 16 to 18, which is physiological as per the child's age. TI is the inspiratory time. Again, you set the TI as per the child's age. For an older child beyond 10 years, TI of around 1 second. For a younger child of around 1 year, TI should be set around 0.4 seconds. So all this has already been taught to you yesterday. So whenever ventilating a child with ARDS, prefer using a cuffed endotracheal tube. So cuffed tube minimizes air leaks. It would help you achieve a good recruitment of the alveoli. It would also prevent aspiration of secretions. So a cuffed endotracheal tube should be preferred when you are ventilating a child with ARDS. So after you are choosing your initial setting, choosing your mode, you start your patient on mechanical ventilation, and then you have to modify your settings. So how do you modify your settings? The modification would depend on what you want. If you want to improve whether you want to improve his oxygenation or you want to improve his ventilation. So oxygenation, again, for improving oxygenation, the best thing is to increase PEEP. Okay, increase the positive end expiratory pressure. That is the most effective strategy of improving oxygenation. Other strategies would include increasing the FiO2, increasing the PIP or tidal volume, increasing the TI or inspiratory time. But these are not very effective strategies. The most effective is increasing the PEEP, because PEEP increases the alveolar recruitment. So more alveoli would open up, so more exchange will happen, and that is going to help your patient with ARDS. If you want to improve CO2 elimination, so CO2 elimination is directly related to your minute ventilation, which is a product of tidal volume and respiratory rate. So अगर आपको CO2 eliminate कराना है, increase the tidal volume, increase the respiratory rate, you would get rid of your CO2. But whenever you are increasing the tidal volume, be very cautious about barotrauma. Okay, so increasing tidal volume is also going to cause barotrauma. So cautiously watch that patient, monitor his plateau pressures. The plateau pressures can be seen on the monitor of your ventilator. You should always aim to keep your plateau pressures below 28 to 29 centimeters of water. If your plateau pressure is going beyond 28, do not increase your tidal volume, because doing so would keep that patient at risk of barotrauma, air leaks, pneumothorax, pneumodiastole. But you should practice permissive hypercapnia in ventilating a child with ARDS. Simply, as I told you in the previous slide, अगर आप CO2 को बहुत ज्यादा टारगेट करेंगे तो barotrauma होने का रिस्क हो जाएगा. So do not increase your settings unless and until the CO2 values are extremely high. So accept high CO2 values till your pH is above 7.2. So जब तक आपका arterial blood gas में pH 7.2 से above है, do not change your ventilatory settings to target this CO2. Tidal volume को increase मत करिए. But there is a contraindication to this. A patient with increased intracranial pressure. Okay, a patient with increased intracranial pressure, CO2 can cause cerebral vasodilation and increased intracranial pressure further. So अगर AES का patient है, तो उसमें आप ये permissive hypercapnia नहीं follow करेंगे. Because in such a patient, if you increase the CO2, then intracranial pressure would increase further. So it is only advised for patients with ARDS, not for those with increased intracranial pressure. Sedation and analgesia are extremely important. These patients are on very high settings of mechanical ventilation. If you want them to cooperate, you have to sedate them. You have to give them some painkillers. So to ensure that patient can tolerate mechanical ventilation and that ventilation is effective, sedate those patients. So sedation can be done by using a midazolam infusion. Initiate the infusion at 1 to 2 microgram per kg per minute, and then titrate it up or down as per the child's need. Fentanyl infusion may be needed because midazolam is an analgesic, while fentanyl midazolam is a sedative, while fentanyl is an analgesic. So fentanyl is also needed. Start it at a dose of 0.5 to 2 mics per kg per hour and titrate it to achieve the desired effect. Neuromuscular blockade with vecuronium, it is not indicated routinely. So neuromuscular blockade should be reserved only for those patients where sedation and analgesia alone are inadequate to achieve effective mechanical ventilation. Patient is fighting too much, is already on high doses of midas and fentanyl. In such patients, you may need to start vecuronium, but never routinely. Patients with ARDS, if their hemoglobin is falling below 7, you should transfuse packed RBCs. If the child is also in unstable septic shock on high inotropic infusion rate, then maintain a hemoglobin above 10. So if the child is hemodynamically stable, not in septic shock, then you can accept hemoglobin which is above 7. Okay. Prone ventilation, it can be tried, but it is again difficult in younger children. There are so many lines here. You would need a good monitoring if you want to ventilate a patient in prone positioning. But it can be tried. There is no contraindication. And for children who are above 12, it can always be tried. So maintaining the child in prone position and then ventilating can improve the lung dynamics and improve the oxygenation. After starting the child on mechanical ventilation, a child with ARDS, what are the things which need to be monitored? First is clinical monitoring. You monitor the vitals of the child, monitor his heart rate, respiratory rate, blood pressure, saturation, the child's consciousness, sensorium, his or her urine output. All these vital parameters should be recorded every 2 hourly. Recording the format should be kept at bedside and values entered so that anyone who is seeing the patient is aware of what changes have been happening over time. Lab monitoring is needed. Such patients would usually need ABG at least 1-2 times a day, plus on SOS basis. On an ABG, always aim for adequate. Don't aim for a normal gas. Don't aim कि मुझे CO2 तो बिल्कुल 35 से 45 के बीच में ही रखना है. Don't aim कि मुझे PO2 तो 100 के ऊपर ही जाना है. So aim for adequate. Anything PO2 above 80, 85 is acceptable. CO2, anything is acceptable as long as pH is above 7.2. So aim for adequate, not normal gases. If you aim for normal, then you would end up over-ventilating, causing more damage than good. Chest X-ray, again on an SOS basis, you may need to do an X-ray to look for what changes happening. X-ray is also needed for confirmation of a diagnosis of pneumothorax. Patients on high ventilatory settings can develop pneumothorax, but pneumothorax essentially is a clinical diagnosis. You have to suspect pneumothorax in any patient where there is a sudden desaturation, sudden increase in oxygen needs. On auscultation, air entry is diminished. On percussion, there is a hyperresonant node, and that side of the chest is not moving. अगर ये सारी चीजें मिल रही हैं, suspect pneumothorax, do a needle thoracocentesis, and see if there is continuous bubbling, that most likely the child had pneumothorax. Don't wait for X-ray confirmation in such a patient, because if you keep on waiting, वो pneumothorax, tension pneumothorax हो जाएगा और फिर obstructive shock हो जाएगा patient. So act as soon as you suspect. Inflammatory markers may need to be repeated every 24 to 48 hours. Then monitoring the ventilation, what things need to be monitored? Look for the chest rise, the chest should be rising. Look for retractions, see the plateau pressure should be kept below 28. Monitor the minute volume, set your alarm limits properly, tidal volume, peak pressure alarm, low tidal volume alarm, high minute ventilation alarm. सारा कुछ आप प्लीज उसमें सेट करें, अदरवाइज अगर आप सेट नहीं करेंगे then ventilator will keep on beeping all the time and you would get irritated, और सही में जब अलार्म होगा you would miss it. So set your alarm limits properly. Avoid frequent circuit disconnection. So there's a habit of doing routine suctioning every 2 to 3 hours. It is never advisable, because whenever you disconnect the circuit, all the alveoli collapse because you lose all the positive pressure which has been generated till now. So again, the alveoli would collapse. Again, you would have to start with high pressure to recruit those alveoli. So avoid frequent circuit disconnections. There is no need for routine suctioning. Whenever you see secretions in the child's endotracheal tube, or there is unexplained hypoxia and you are not able to find any cause, you are suspecting that there is a tube block, then only you should suction. If you have access to inline suction, then that is always preferred. You will not need to disconnect the endotracheal tube because inline suction can be done even with ventilation going on. Also monitor the sedation adequacy. This can be monitored by giving a daily sedation holiday of 1 hour to monitor the child's consciousness. So सुबह के time में जब staffing आपका adequate होता है, stop your sedation for 1 hour to check how is the child's sensorium. कहीं वो comatose तो नहीं हो गया. So stop his sedation, look what is happening, and then again you may have to start it to again regain the initial sedation which was giving. So because you have to wean the child, weaning आप तब तक नहीं कर पाएंगे जब तक आपको child का sensorium पता नहीं रहेगा. For that you have to give a sedation holiday daily. Now whatever we have discussed, we will try to put things together with a case scenario. So this is a child, a 6-year-old girl with severe COVID. She arrived in our emergency department with a history of being unwell for 7 days. So she had fever, cough, and progressive respiratory distress. When she was seen, the child was agitated. Her airway was clear, so she was breathing and airway was clear, but she had severe respiratory distress with retractions. Child was immediately started on high flow nasal oxygen because of the respiratory distress she was on at 30 liters per minute at a FiO2 of 100%. But even on this setting, which was almost the maximum for her age and weight, her SpO2 was still below 85%, only 84% saturation. She also was having tachycardia, but was febrile as well. Her blood pressure values were normal. She had warm peripheries. And arterial blood gas was done, and it showed a pH of 7.47, PCO2 of 30, and PO2 of 50. So you can see there is respiratory alkalosis. So pH is high, CO2 washout is there, so there is respiratory alkalosis along with hypoxemia. So on a non-invasive mode of ventilation, HFNO, child is still hypoxic. So what should we do? So we had option of using BiPAP or NIV, but because this child was extremely agitated, we decided against using that because child might not have tolerated BiPAP. So we decided to put this child on mechanical ventilation after intubating. So whenever you intubate a child, always follow the rapid sequence intubation, which was taught to you yesterday. Pre-oxygenate such children, because अगर आप उसको pre-oxygenate अच्छे से नहीं करेंगे, आपने sedate कर दिया, child may develop cardiorespiratory arrest during the process of intubation. So give her atropine, pre-oxygenate, give her sedation, give her muscle relaxant if it is a difficult airway, you are unable to open her mouth. So give her muscle relaxant and then gently intubate her without too much fuss, without too much injury. Because if you injure the vocal cord, तो बाद में extubation में बहुत problems होंगी. So ventilation and intubation should always be a gentle process after following the rapid sequence intubation technique. So once you have decided to intubate and you have intubated, secured the airway, another doctor or another physician who is available there should start setting the mechanical ventilation. So what settings we would use? Again, I already discussed, we would choose a mode. So mode, you can choose either volume SIMV or volume assist control, or even pressure SIMV or pressure assist control, whichever you are more comfortable with. We are more comfortable using the volume mode. So we chose volume SIMV plus pressure support for this child. Tidal volume of 6 ml per kg. So she's 15 kg. A tidal volume of 90 ml was chosen for this child. PEEP 8 because she's hypoxic, having severe ARDS. So we started with a higher PEEP of 8. For an 8-year-old, a respiratory rate of 20 is physiological. So we set the rate at 20. We have set the TI at 0.8 seconds, which is again physiological, and start with a FiO2 of 100%. We also, because she was on VI SIMV plus pressure support, we have set a pressure support of 10 centimeters of water along with this. And a good sedation and analgesia has been started by continuous infusion. A central venous catheter has been secured because she has to be on so many infusions. So securing a central catheter is always advisable. And a muscle relaxant may be needed if she is not getting sedated, not tolerating the mechanical ventilation with sedation and analgesia. So after starting on these settings, because the child was not, her oxygenation was not improving, we gradually increased the PEEP till we reached the PEEP PEEP of 16. So at a PEEP of 16, this child was stabilized. Then once her oxygenation parameters improved, the target saturation of beyond 88% was achieved, we started to decrease her FiO2. So जैसे ही आपका target achieve हो जाता है, आप FiO2 को पहले कम करेंगे. And don't start reducing the PEEP because PEEP is keeping the alveoli open, keeping the lung in a recruited state. If you start reducing the PEEP तुरंत, तो alveoli would again start collapsing. सारे alveoli वापस बंद हो जाएंगे. Start reducing the FiO2. So FiO2 of 60% is what at which we are happy because FiO2 60% आप किसी भी oxygenation device से achieve कर सकते हैं. So once you are at an FiO2 of 60% on good sedation analgesia, child should already be on NG feeding because कोई shock है नहीं उसको, so should be on feeding as well. Keep a watch on the child's plateau pressures. So keep a watch on plateau pressures. Plateau pressures अगर बढ़ जाएंगे तो start reducing the tidal volume. Okay. So जब patient in settings पे stabilize हो गया, now we have to consider weaning this child. How do we wean such a child? So weaning is again has already been discussed. I'll just tell you what we did for this child. So assist control mode is not a weaning mode. Okay, you cannot wean a child on assist control. आप rate क्योंकि आप control ही नहीं कर रहे हैं. जो भी patient का rate है, all those breaths would be controlled by the ventilator. So if you want to wean a patient, shift this child to SIMV mode. So we shifted her to volume SIMV mode, and then we started to decrease her PEEP gradually. 16 ka PEEP improve ho gaya hai. Now we will start reducing the PEEP. We reduce the PEEP to 16 to 14, 14 to 12, 12 to 10, 10 to 8, and so on. So PEEP ko gradually reduce karke we have to reach the physiological PEEP of around 4 to 6 centimeters of water. जब physiological PEEP पे हम reach कर गए हैं, Then rate of 20 is again physiological. You can start to reduce that rate gradually, 20 say 18, 16, 14, 12. And जब इन settings पे patient stable हो जाएगा, then we would change the mode to a spontaneous mode, that is CPAP or CPAP plus PSP. So PSP is a spontaneous mode. Patient, if he or she is maintaining on PSV, which means that patient is fit for extubation, क्योंकि वो सब कुछ खुद कर रहा है, ventilator बस थोड़ा सा उसको support कर रहा है. We give a spontaneous breathing trial of 2 hours for such a patient, and if the child passes the SBT, we would extubate the child. So this is how we manage a child with COVID pneumonia due to ARDS. Along with the ventilation, of course, you would use steroids for this child. You can consider using remdesivir because ये 8th day of illness पे है, not beyond the 10th day. तो remdesivir अगर आपके hospital में permission है use करने का, you can use remdesivir. Use steroid. We started with ceftriaxone as well because she was having severe COVID pneumonia. So use these drugs, restrictive fluids, good amount of nutrition, RT feeding initially start kariye, gradually build up kariye, and then once the child is extubated, she can be put on simple face mask, and then if the child is improving, to a nasal prong and then room air. So the take home message from my presentation is always focus on the basics. Patients with ARDS tend to be on long time, on ventilation for long days. So you have to keep infection prevention on your fingertips. So you cannot allow these children to develop VAP because COVID से lungs already compromised. अगर उसको VAP हो गया, so further आपकी complications बढ़ जाएंगी. So focus on basics, infection prevention, nutrition, hand hygiene, extremely important steps for improving the outcome of these children. Drugs like steroids, remdesivir, no low molecular weight heparin, none of these drugs is a miracle. Right patient, right time does the trick for you. Ventilation is a blend of art and science. So spend time with the patient, spend time with your machine. अभी जब patients आपके पास COVID के नहीं हैं, spend time with your machine, test लंग लगा के सारी चीजें देखिए कि उसमें कौन कौन सी मोड्स हैं, कैसे कैसे आप वेंटिलेट कर सकते हैं, क्या ट्रिगर्स सेट कर सकते हैं, कैसे आपको एपनिया मोड देखना है. सो गो एंड स्पेंड टाइम विद योर मशीन. हर मशीन के साथ एक मैनुअल आती है. मैनुअल इज एक्सट्रीमली डिटेल्ड डिस्कशन होता है उस मशीन के बारे में. सो गो थ्रू द मैनुअल ऑफ दैट मशीन. If you are ventilating a patient, ventilate gently with low tidal volumes. High tidal volume will cause barotrauma, so be careful. Always aim for acceptable and not normal, because aiming for normal will again cause more injury to the patient. No matter what you do, a good amount of such patients with severe COVID pneumonia, with COVID ARDS are going to succumb to their illness. So nature of illness must be communicated with the families. Talk to them, explain them about the nature of illness, explain them what treatment you are doing and the daily progress. This is going to help them in coping with the child's illness and coping with whatever outcome is going to happen. So this was all about the lecture on severe COVID pneumonia. This is the additional material from where I had taken for this lecture. And these are, I would thank all the contributors for this lecture. Thank you.
Thank you very much, sir, for this talk. Beautiful talk. Now we are going for lunch, and we will join again at 2 p.m. And Dr. Aisha Ahmed will be discussing about MISC diagnosis and its management. So again, we will be joining at 2 p.m. Thank you.
I hope all the participants are back after the lunch. So I request Dr. Aisha to please start the session. So the next talk is on MIS in children, and that will be taken by Dr. Aisha Ahmed from AMU Aligarh. So welcome, Dr. Aisha.
Okay. Thank you so much, Dr. Chandrakanta. Just a moment. Can you see the slide?
Yes, it's visible.
Okay, so do I start?
Yes, please.
Just a moment. Okay, so good afternoon, everyone, and welcome to this post-lunch session. So this talk is about MISC, that is multisystem inflammatory syndrome in children, which we now know as a unique and novel manifestation of COVID infection, and which is more commonly seen in children. So that's why, because though we have seen cases of MIS in adults, but this syndrome, this hyperinflammatory syndrome, is somewhat more commonly seen in children, and it involves multiple system, and so therefore the name of this condition. So the learning objective of this talk would be, I would try to cover certain aspects of when to suspect a child with MISC, what are the typical manifestation which will make you think and suspect about MIS, and how do you investigate and how do you manage a case who is subsequently diagnosed to be a case of MISC. So coming to the first, what actually is this condition? Because all of us have heard this about this term in recent times only. Nobody has heard about something like this even before, though we had been having viral outbreaks before as well. But this COVID has taught us many new things, and this MISC is one of them. So it is a multi-system hyperinflammatory syndrome that follows exposure to SARS coronavirus infection by 2 to 4 weeks and affects children and adolescents. So important for you to remember here is what are the different, what is the catch here? It is a hyperinflammatory syndrome, okay? And it follows exposure to COVID infection. So once a child has been exposed to this coronavirus, so this is something which takes time to develop, and it happens usually after 2 to 4 weeks after the child has acquired infection, and it affects children and adolescents. Though adults have been affected, but this is something which is more frequently seen in during childhood. And the first case was reported in last year as early as April 2020, when nobody knew about this syndrome. And there were many speculations because there were children who presented with many atypical manifestations. Some of them, they presented with like cardiac involvement and Kawasaki disease, but they were not qualifying and falling into the criteria of typical or even atypical Kawasaki disease. And there was clustering of cases. And this was something which was observed globally. Like it started in early in the year 2020 in European population. Then subsequently it was observed in our country as well, especially in this year. So this was something where one thing was common, that they had some manifestation which could be due to hyperinflammatory response of the body, and it was more predominantly seen in children. And this year we saw many cases, and we have a plethora of case presentation and case series which have been published, and few are under publication. We have got a lot of cases of MISC. So that's why this topic has been included in this training per se. So how common is that? So if you consider MIS as the total number of cases, total number of COVID cases in children, so MISC forms a very small proportion. But if you consider in the last few months, the outbreak that all of us saw, then definitely it's not so uncommon as well. So if you consider other tropical infections, so definitely this is something which is not so commonly seen, but we are too early to say. We don't know what is going to happen subsequently, and maybe we can have more cases. But as of now, if you consider total COVID cases among all children, then definitely MISC is not such a common disorder. What causes MISC? So why this? I'm sure everybody, each one of you agrees with this, that children, they behave to this COVID in a different manner from that of an adult. So they have different manifestation. So what is the reason why children, they do not have the typical manifestation, why the mortality is not high among children, and why they behave differently? So it has been postulated but scientists, the research is still going on, but it has been postulated that perhaps it is because of immune dysregulation. Though it's still now we cannot say what is the exact pathogenesis, but one thing is for sure that it is because of the immune dysregulation. That is, the children mount somewhat different inflammatory response, and that is more intense, that is more hyper-inflammatory response to this coronavirus infection, the SARS coronavirus infection, and that's the reason they behave differently. So perhaps this is the reason, this is the basis why children, they have manifestation of MIS and not proper COVID per se. So this is a cartoon, a picture showing the pathogenesis of MIS. As you can see here, what happens when the child acquires, when a person acquires COVID, the SARS coronavirus infection. So as you know, it gets lodged in the upper respiratory tract, in the nasopharynx. And in children, for reasons not again exactly clear, it does not go into lower respiratory tract infection. Usually, most commonly, it does not. That's why the children, they do not have the typical LRTI and the lung involvement that we get to see in adults, but they mount this virus acts as an antigen, or rather super antigen. So it leads to production of activation of both the immune system, both the types of, both the arms of immune system, that is both the humoral as well as T-mediated, cell-mediated immunity. So the body mounts antibody response, and the body also produces, because of activation of the helper cells. So there is production of interleukins, the chemokines, the tumor necrosis factor alpha, interleukins, interferons, and which causes all the manifestation. So there is a term called cytokine storm because of the infection, and this cytokine storm takes time to develop. So that is why it is hyperinflammatory response, and it happens 2 to 4 weeks after the child acquires infection. So in some children, there is very intense cytokine storm or a cytokine response, which can cause affection of almost any system of the body. So what happens, the child may have presentation with neurological involvement, aseptic meningitis, the child may have mucocutaneous manifestation, the child may have cardiovascular involvement, the child may have hepatic involvement, gastrointestinal. And this was the observation which we have been observing in India as well, that many children during the clustering, during the outbreak, they had more presentation of cardiac involvement and gastrointestinal involvement, and they had typical rash. So that made us think about Kawasaki, but they were not qualifying all the criteria. So perhaps this was MISC. So, and whether direct virus invasion causes all the disease, it's not so much sure, but it has been postulated perhaps it's not so contributory to development of all the manifestation as is the response. So that is the reason that after the child acquires infection, it takes to few weeks time when the child mounts this response and has all this manifestation of MISC. So again, coming or explanation of the same thing. So there can be two scenarios, like in certain children, the children, once they acquire the viral infection, so this is the normal response of the body to mount an immune response against that infection. So this is, as you can see on the left side, so there, whenever the child acquires infection, the body responds by producing interleukins, by producing chemokines, and also there is production of antibodies. So in certain children, when the viral load is low, so what happens? There is the viremia that gets cleared, and subsequently at the same time, the body has a seroconversion. There is production of antibodies. There is a very good interferon and early interferon response, and the child clears himself or herself of viremia. And these are the children who presented with, who have mild disease. Okay, vis-a-vis on the opposite extreme, you have few children where the viral load was high. Okay, so what happened? They had viral infection, and in those children, not only this response was early, but it was also more intense and more prolonged, as you can see here. So response बहुत देर तक रहा और बहुत intense हुआ. तो chemokine response इनमें ज़्यादा intensity के साथ produce हुआ, or this viremia took a longer time to recover. Okay, so these are the cases which had or which may have or subsequently in the future will have more severe disease, and even MISC is one of them. So यही कि perhaps इस वजह से maybe our diagnosis, we were missing many cases because there were some children who had mild disease, जिनमें अपने आप ही asymptomatic होके clear हो गया, in which we could not suspect. Or and there were certain children who had more severe in manifestations, उनके अंदर response भी बहुत intense था, and which caught our attention और जिनको admit करके treatment देना पड़ा. And why some children have low viral load and why some have high viral? Exactly, again, as I keep saying, MIS is the new, or even COVID is a new idiopathic. We don't know कि क्यों ऐसा होता है, but perhaps genetic basis, or perhaps it depends upon the innate or the immune system of the body. बच्चा already जो infected है, उसकी immunity कैसी है? So they mount different response, and so is the manifestation of MIS. So MIS, because it is hyper-inflammatory response, so inflammatory response, so it can lead to system or clinical features pertaining to any system of the body. As I said, बहुत confusion था और अभी भी है, because they presented with like CNS involvement, altered sensorium, behavioral abnormalities. कुछ थे जो cardiac sudden onset of shock और myocarditis लेकर आए, कुछ जो था वो gastroenteritis, abdominal pain और loose motions, कुछ hepatic involvement जो है liver failure के features लेकर आए. So the features were very non-specific, but there was a clustering of cases and they had something atypical. Like उस वक्त COVID के cases adults में ज़्यादा हो रहे थे, and after we saw a decline in the peak of the COVID cases, बच्चों में हमारे पास ये cases आना शुरू हो गए. Then biochemical parameters में we had not 100%, but a lot of them, they had thrombocytopenia and they had low total leukocyte count with a relatively neutrophilia. The total counts come, neutrophils ज़्यादा. So this was the presentation of MIS in children. So as you can see in this picture, again, this is strawberry tongue. So we saw, the moment we see a strawberry tongue, we think about Kawasaki disease, mucocutaneous manifestation. So all of a sudden there was an upsurgence in the incidence or of this myocarditis, this Kawasaki, atypical Kawasaki disease. So these were actually the manifestation of MIS. So if you talk about the clinical spectrum of this condition, so clinical spectrum like is any other condition. So again, there is a huge spectrum where you have 3 classes. The children, they can have either class 1, 2 or 3, they can fall into 1, 2 or 3 classes. So class 1, but each one of them had equal representation, like 1/3 of cases, they had representation in each of these classes, each of the 3 classes. So class 1 में the children, they had more of gastrointestinal and cardiovascular involvement, and more than 6 systems were involved. And this is something जो हमारे यहाँ पर case study जो इंडिया में cases आए हैं, which observation not only in India but globally has been. So class 1, which is milder form, in which most of the children had about close to 100% of the children, they had antibody positive. Okay, and the mortality, the best part is the mortality was low. Okay, so they had multi-system involvement, multi-system inflammatory system disease in children. Okay, so multi-system inflammatory syndrome. So more than 6 systems were involved, बहुत ही अलग-अलग system का presentation था, and they had a serology positive. तो इसीलिए हम सिर्फ RT-PCR से नहीं, जहाँ पर भी आप MIS suspect कर रहे हैं, तो आपको antibodies भी करानी चाहिए, because a lot of children, they present with antibody positive in this condition. Then class 2nd, now this was the class जिसमें सबसे ज़्यादा confusion है, because these are the children who had involvement of respiratory tract as well, like lung का involvement, LRTI, lower respiratory tract infection. तो उसमें the children, they had involvement जैसे कि simple COVID में ही होता है, and to add to your confusion, 84% of them, they had RT-PCR positive as well. तो इसमें जो है वो COVID से confusion हुआ कि this is COVID per se या this is something which is post-COVID, जिसको हम MIS कहते हैं. And again, to add to the woes, the mortality is the highest in this class. So how to differentiate, I'll come to it in a moment later. And the class C, where they presented with Kawasaki or atypical Kawasaki disease. इसमें भी they could have 1/3 could have serology and RT-PCR both positive, and 2/3 they had serology positive. इसीलिए MIS के workup में हम serology, हम antibody levels करा के जरूर देखते हैं. And again, the best part as class 1 is कि mortality rates are really low. अगर आप treatment provide कर देते हैं well in time, in the most of them they do respond. Okay, so how to differentiate? जो हमने बात की, especially MIS with COVID-19, whether this is acute infection, especially class 2, जहाँ पर respiratory tract involvement ज़्यादा था. So as I said, कि MIS के cases में ज़्यादा observation, this is not 100%, this is not the rule, but commonly, the most common हमारी observation है, that is children who have MIS, they have more involvement of cardiac as well as gastrointestinal system. Okay, तो उनमें gastrointestinal manifestation cardiac के साथ unexplained shock लेकर ज़्यादा आए थे. Mucocutaneous manifestation could be, could not be. 2/3 cases में they had mucocutaneous like rashes, like petechiae, maculopapular rashes लेकर आए थे. And as we compare it with COVID, तो COVID में respiratory tract, lung involvement, ARDS. In the severest cases, they had ARDS-like picture. वो presentation ज़्यादा थी if you want to compare it with COVID-19. Or if you compare the biochemical parameters, as I said, कि so CRP levels हैं वो COVID-19 से ज़्यादा MIS में they were raised in hundreds, and also the TLC was reduced, और जिसमें भी neutrophil counts were, a proportion of neutrophils was high. So these can act as clue to help you in deciding between MIS and COVID-19, and how to differentiate class C like MIS में versus Kawasaki disease. So broader age range, like MIS के बच्चे 1 महीने से लेकर 13 साल तक, we had almost all, none of the age was spared. हर उम्र के बच्चे ये conditions लेकर आ रहे थे. They had more of gastrointestinal and cardiac involvement. They may or may not have mucocutaneous involvement. They presented like unexplained shock, unexplained जो है वो neurological involvement. Okay, so these cases were more commonly seen in MIS as compared to Kawasaki. And again, going for the biochemical parameters, like children with MIS, they have lower platelet counts, whereas thrombocytosis is more commonly observed in Kawasaki. And they had total absolute lymphocyte count was reduced, whereas neutrophil counts was increased. And they had again inflammatory, because inflammatory marker hai, so CRP levels were more raised in children with MIS as compared to Kawasaki disease. Okay, and how this MIS is going to affect and what after effects or what long-term morbidity this MIS can have, still it's not known. Like Kawasaki disease per se can cause coronary abnormality in 1/4 of the children, as we know, but we are not sure about MIS as of now. So how to investigate? कब हम suspect करेंगे और कैसे investigate करेंगे? So there are 2 tiers of investigation. We have 2 levels of investigation, and we have to look at the clinical presentation of children. So there can be again 2 situations. One is where the child presents in life-threatening, like shock-like episode है, या cardiac dysfunction है, या बिल्कुल acute life-threatening event है. So then and there you have to subject the children to both tiers of investigation simultaneously, because the child is sick. तो आप ट्रीटमेंट स्टार्ट करेंगे और साइमल्टेनियसली उसको टियर 1 और टियर 2 जो है इन्वेस्टिगेशन स्टार्ट करेंगे. एंड द अनदर सिचुएशन कुड बी दैट द चाइल्ड यू हैव दिस प्रेजेंटेशन बट ही इज इन अ रिलेटिवली स्टेबल कंडीशन. ठीक है, तो उसमें कब हम सस्पेक्ट कर रहे हैं? फीवर है, स्पेशली अगर 3 डेज से ज्यादा और अब तो इवन 1 डे से ज्यादा अगर फीवर है, एंड द क्लिनिकल फीचर्स लाइक एक से ज्यादा सिस्टम इन्वॉल्व हो रहे हैं, म्यूकोक्यूटेनियस इन्वॉल्वमेंट है, कार्डियक है, अनएक्सप्लेन्ड ऑल ऑफ अ सडन. एंड दिस 0.3 आई वुड से कि 0.3, और स्पेशली जब हमारे पास आउटब्रेक आया था तो दिस वाज फाउंड टू बी पॉजिटिव इन ऑलमोस्ट 100% ऑफ द केसेस. हर फैमिली में आपको ये पॉजिटिव तो मिल ही रहा था कि किसी ना किसी को कोविड हुआ है या एक्सपोजर हुआ है. सो अगर ये सारी कंडीशंस मीट करता है बच्चा, देन यू हैव टू सी कि बच्चा स्टेबल है कि अनस्टेबल है. अगर स्टेबल है तो आप उसको पहले इन्वेस्टिगेट करेंगे, फिर आप देखेंगे टियर 1 फॉलोड बाय टियर 2, फिर आप डिसाइड करेंगे कि या कोई ट्रॉपिकल इन्फेक्शन है या दिस इज MIS. और अगर बच्चा अनस्टेबल है तो आप दोनों चीजें जो है वो साथ में कराएंगे. सो अगेन out of these 5 criteria, just to help you in arriving at a diagnosis, out of these 5 criteria 2 होने चाहिए सिर्फ तभी, क्योंकि इतना नॉन स्पेसिफिक मैनिफेस्टेशन है कि anybody is bound to get confused. तो इन 5 क्राइटेरिया में से 2 क्राइटेरिया होने ही चाहिए. like if you can see mucocutaneous manifestation है, bilateral non-purulent conjunctivitis जैसे हम कावासाकी में देखते हैं. if the child presents in बिल्कुल unexplained sudden onset shock या hypotension में है, myocardial dysfunction, myocarditis, valvulitis, coronary artery abnormalities अगर आपने एको करा के देखा, coagulopathy का evidence है. So presence of any 2 of these criteria, you should evaluate the child for MIS. So what is the tier 1 evaluation? Step 1 हम कैसे करेंगे? एक complete blood count कराएंगे, एक metabolic profile करके देखेंगे, liver function, liver और इसके किडनी फंक्शन टेस्ट कैसे है, ब्लड ग्लूकोज लेवल कैसा है, और स्पेशली क्योंकि इम्यून रिस्पॉन्स है तो आपको CRP और ESR से चेक करना है कि बॉडी का इन्फ्लेमेटरी हाउ द बॉडी इज रिस्पॉन्डिंग. एंड द सार्स कोरोना वायरस की आपको सीरोलॉजी और PCR, मतलब PCR के साथ आपको सीरोलॉजी जरूर करानी है. सो व्हाट कॉन्स्टिट्यूट्स अ पॉजिटिव स्क्रीन? अगर CRP more than 5 है, okay, and that depends upon the lab, and in the present मतलब both should be positive, ESR is more than 40, and at least one of the following. तो एब्सोल्यूट जो लिम्फोसाइट काउंट है लेस देन 1000 है, क्योंकि न्यूट्रोफिल्स बढ़ रहे हैं, लिम्फोसाइट काउंट्स आर लो, थ्रोम्बोसाइटोपिनिया है, हाइपोनेट्रीमिया है, और द पेशेंट हैज हाइपोएल्बुमिनेमिया. तो अगर बायोकेमिकल ये सारे पैरामीटर्स हो रहे हैं, दिस कॉन्स्टिट्यूट्स मतलब द चाइल्ड हैज पॉजिटिव स्क्रीन. और फिर हम नेक्स्ट ईयर जो लेवल 2 इन्वेस्टिगेशन, टियर 2 इवैल्यूएशन वो करेंगे, दैट इज मोर स्पेसिफिक. ठीक है, हमने स्क्रीन किया, अब अगर वो स्क्रीनिंग हमारा पॉजिटिव आया तो हम टियर 2 में कार्डियक इवैल्यूएशन करा के देखेंगे, बिकॉज मोस्ट ऑफ द चिल्ड्रन दे हैड कार्डियक इन्वॉल्वमेंट, एंड ऑल्सो immune inflammatory markers, because hyperinflammatory response है, just keep that thing in mind. तो हम उसके लिए चेक करके देखेंगे क्या क्या हो सकते हैं पैरामीटर्स, प्रोकैल्सिटोनिन, प्रोथ्रोम्बिन, एपीटीटी, डी डाइमर्स, ट्राइग्लिसराइड लेवल्स, फिब्रिनोजेन and cytokine panel if that facility is available, and blood screen. So let's talk about what constitutes a positive screen. तो cardiac में हम ECG तो देखेंगे, ECG के अलावा always you should subject the child and get one echocardiography done always. तो echo में आप क्या देख सकते हैं, if there is any evidence of left ventricular dysfunction and the ejection fraction is less than 35, that is really positive and something you should always take seriously. And there is coronary artery dilatation. तो जब भी आप echo कराएंगे तो you should always request your cardiologist to comment upon the coronary artery dilatation, और Z score उसका calculate करते हैं कि कितना है उसका जो उसका diameter है. So if it's, और इसका क्यों है, इसका therapeutic implication, I'll come to it in a while. तो आप उसका diameter के बारे में जरूर comment करते हैं और valvular dysfunction के बारे में. And inflammatory markers में आपको D dimers like हमारे यहाँ 10,000s में और 1000s में positive आ रहे थे, you should always see अगर more than 5 times जो upper limit of normal दिया हुआ है लैब में, so that has to be taken as positive. Cytokine panels and a blood smear which may have a non-specific changes as well. So there are definite bodies. जब इतने सारे cases आए थे, so every international जो हमारी recommendation bodies होती है, they come up with their own recommendations, and so WHO came up with the criteria कि क्या criteria हो सकते हैं. तो all 6, तो बस याद रखना है कि ये सारे criteria होने चाहिए. So the child this condition is suspected in person between from birth to 19 years of age. किसी भी age group में fever for more than equal to 33 days if it's present, multi-system involvement, like एक से ज़्यादा system अगर involved है, and evidence of inflammatory markers, procalcitonin, CRP, cardiac है तो pro-BNP, PSR, ये सारा positive होना चाहिए, and exclusion of it. Like last ये जो 2 criteria हैं, these are very challenging at times, क्योंकि आपको अदर डिजीजेस लाइक कभी कभी होता है अगर आपके यहाँ पर आपको लग रहा है कि जैसे इस सिनेरियो में हमारे पास डेंगू बहुत केसेस आ रहे हैं, लाइक यू हैव मलेरिया केसेस, पहले हमारे पास एंट्रिक आ रहे थे या सिंपल गैस्ट्रोएंटेराइटिस आ रहे हैं, तो दोज इन्फेक्शन शुड बी एक्सक्लूडेड फर्स्ट. ठीक है, तो ऑलवेज थिंक ऑफ कॉमन थिंग्स फर्स्ट. जो आपके यहाँ कॉमन, अगर कॉमन कंडीशंस जो आपके यहाँ केसेस आ रहे हैं, सो यू कैन नॉट इग्नोर दोज केसेस, बट एट द बैक ऑफ द माइंड यू शुड हैव दिस थिंग इन योर माइंड कि हाँ देयर इज वन थिंग कॉल्ड MIS, और अगर इसको नहीं क्वालिफाई कर रहा है टिपिकल फीचर्स, तो यू शुड ऑलवेज थिंक अबाउट MIS. एंड द 6th पैरामीटर आज के सिनेरियो में आई कैन से कि इतना एपिडेमियोलॉजिकल लिंक इतना कॉमन क्योंकि हमारे पास नहीं आ रहे हैं, बट एज द केसेस आर पिकिंग, जिस तरह से हमारे यहाँ अभी भी स्पोरेडिक केसेस आना शुरू हो रहे हैं, सो मे बी दिस विल ऑल्सो बी पॉजिटिव. तो जब अगर फैमिली में ऐसा नहीं ऑल ऑफ अ सडन एक बच्चा आपको MIS लेके आ जाएगा, सो यू हैव टू see the child in toto and you have to see that the child meets all the 6 criteria only then. So there is no point in getting the child investigated for all the investigations because there is no definitive lab criteria for MIS. लेकिन अगर आपको features बहुत strong suspicion लग रहा है और ये सारे criteria fulfill हो रहे हैं, तभी आपको जो है वो टेस्ट कराना चाहिए. As I said, because कोई specific एक pathognomic test नहीं है कि जिससे आप MIS को डायग्नोस कर सकते हैं. सो कमिंग टू द मैनेजमेंट पार्ट, जब हमने डायग्नोसिस कर लिया, सो हाउ डू वी मैनेज. ठीक है, तो मैनेजमेंट क्या होगा, जो उसके मैनिफेस्टेशंस हैं. सो मैनिफेस्टेशंस क्यों हो रहे हैं, बिकॉज ऑफ द हाइपर इन्फ्लेमेटरी, इम्यून डिसरेगुलेशन, हाइपर इन्फ्लेमेटरी. सो ऑल दैट वी हैव टू डू इज टेक केयर ऑफ दिस हाइपर इन्फ्लेमेटरी स्टेट. तो हम कैसे कर सकते हैं, इम्यूनोग्लोबुलिन्स एंड कॉर्टिकोस्टेरॉइड्स आर द बेस्ट बेट हियर. तो इम्यूनोग्लोबुलिन्स और कॉर्टिकोस्टेरॉइड्स जो है स्टार्ट करते हैं एज फर्स्ट लाइन ऑफ मैनेजमेंट. एंड बायोलॉजिकल एजेंट जो रिसेप्टर इंटरल्यूकिन रिसेप्टर एंटागनिस्ट होते हैं, बहुत ही कॉमनली अवेलेबल नहीं है, बट इफ द चिल्ड्रन दे नॉट रिस्पॉन्डिंग द फर्स्ट लाइन, देन यू शुड ऑलवेज go for the second line. And for the procoagulant state, because of this cytokine response, procoagulant state है, plus left ventricular dysfunction है, and coronary artery abnormalities है, so the child is bound to be in a procoagulant state, which can cause damage maybe abhi or maybe few years down the line. So you have to take care of that as well, and supportive management like in any disorder. So this is an algorithm showing a child who has been hospitalized with MIS. So you have to look whether the child is in acute life-threatening episode. He has come with this acute presentation like in a critically ill child, या फिर stable है. If the condition is like life-threatening है, वो multi-organ dysfunction लेकर आया है, या फिर से shock लेकर आया है, या cardiac dysfunction, neurological बिल्कुल severely critically ill है, तो you have to start treatment और साथ में फिर आप tier 1 और tier 2 evaluation करते हैं, but patient stabilization and management should be your priority. तो आप मिथाइलप्रेट स्टार्ट करते हैं, इम्यूनोग्लोबुलिन देते हैं, इट हैज टू बी गिवन स्लो 24 to 48 आवर्स, और अगर कार्डियक डिसफंक्शन का एविडेंस है तो आपको और स्लो देना होता है, मे बी 96 आवर्स, 36 to 96 आवर्स, डिपेंड्स अपॉन कार्डियक डिसफंक्शन कैसा है, एंड यू हैव टू मॉनिटर, कीप मॉनिटरिंग उसके वाइटल पैरामीटर्स और हीमोडायनामिक स्टेबिलिटी के लिए। और अगर आपका बच्चा स्टेबल आया है, लाइक कोई एमओडीएस नहीं है और साथ में इन्वॉल्वमेंट नहीं है, ही इज एमआईएस बट इन अ रिलेटिवली स्टेबल स्टेट, तो आप पहले जो है वो ट्रॉपिकल इन्फेक्शंस को एक्सक्लूड करना है आपको, जो आपके यहाँ कॉमन है आपके सेटअप में, एंड देन यू हैव टू स्टार्ट द चाइल्ड ऑन IVIG और मिथाइलप्रेट. So मिथाइलप्रेट has to be given in the dose of 1 to 2 milligram per kg per day. ठीक है, if the child does not respond, अगर ऐसा सिचुएशन होती है रिस्पॉन्ड नहीं करता है, तो आप IVIG का डोज रिपीट कर सकते हैं और मिथाइलप्रेडनिसोलोन का डोज आप 2 से बढ़ाकर 10 तक भेज सकते हैं if the child is not responding to your first year management. Okay? और अगर नहीं कर रहा है फिर आप बायोलॉजिकल एजेंट्स लाइक एनाकिंड्रा वगैरह, दे कैन बी गिवन इन द सेकंड स्टेट इफ द चाइल्ड डज नॉट रिस्पॉन्ड, बट most of the children fortunately they did respond to this first line of management. So what is the role of anticoagulant, because it procoagulant state होती है, तो aspirin if the child does not have thrombocytopenia 80,000 से ऊपर काउंट्स हैं, तो you can start aspirin. और स्पेशली जो हमने Z स्कोर की बात की थी, अगर Z स्कोर इज मोर देन कोरोनरी आर्टरी का जो डायमीटर है, Z score is more than 2.5, that means the child has to be started on aspirin. और अगर जो है वो 2.5 rather 10 से ज्यादा है और evidence of thrombosis है, तो और या फिर जो है वो hepatic ejection fraction less than 35% है, तो you have to put the child on low molecular weight heparin as well. ठीक है, for how long to give? So for how long to give? Usually steroids हम 3 to 5 days देते हैं और फिर 25% weekly करके आप next 3-4 weeks में उसको gradually taper कर सकते हैं. For aspirin, it has to be given for 4 weeks, and then depending upon the residual disease, आप बच्चे की coronary artery check करते हैं, बार repeat echo से, if that is doing normal, then you can gradually, platelet counts are better, so gradually you can reduce the dose of aspirin, and same holds true for noxaparin also. So it has to be given for 2 weeks, और आप monitor serially monitor कर रहे हैं, if the coronary artery score 10 से जो ज़्यादा था वो better हो रहा है, जो कार्डियक लेफ्ट वेंट्रिकुलर डिसफंक्शन था, दिस इज आल्सो गेटिंग बेटर, तो धीरे धीरे करके विद एडिक्वेट बायोकेमिकल एज वेल एज जो आपका ये इकोकार्डियोग्राफी मॉनिटरिंग है, इसके साथ मॉनिटर करके यू कैन स्टॉप. इफ द चाइल्ड प्रेजेंट्स, ये तो हमने डेफिनेट ट्रीटमेंट की बात की, इफ द चाइल्ड हैज कार्डियक डिसफंक्शन, सो लाइक सपोर्टिव मैनेजमेंट, दिस इज व्हाट सपोर्टिव मैनेजमेंट इज. कार्डियक डिसफंक्शन कभी कभी शॉक में भी लेकर आएगा, सो यू हैव टू टेक केयर ऑफ दैट एज वेल टिल द चाइल्ड गेट्स बेटर. तो आप उसका कार्डियक जो है वो सपोर्ट, कार्डियक मे बी ही रिक्वायर्स एनोट्रोपिक सपोर्ट, दैट डिपेंड्स अपॉन द केस, और फिर आप उसको धीरे धीरे इकोकार्डियोग्राफी और क्लिनिकल मॉनिटर प्लस बायोकेमिकल मॉनिटरिंग के साथ यू कैन प्रोवाइड सिम्प्टोमेटिक एंड सपोर्टिव केयर टू द चाइल्ड. एंड लाइक रेस्पिरेटरी फेलियर है, तो रेस्पिरेटरी फेलियर के टाइम्स पे आप मैनेज करेंगे. अगर हेपेटिक डिरेंजमेंट आता है, सो यू हैव टू टेक केयर ऑफ कोगुलोपैथी. सो डिपेंडिंग अपॉन द केस यू हैव टू provide a good supportive care and with a timely and effective supportive care. As I said, most of the children, they did respond to our treatment. So coming to the outcomes. So outcomes, again, the same thing. The acute outcomes have been good. ठीक है, mortality rate बहुत कम है, और ये हमारे इंडिया में ही नहीं सारी जगह देखा गया है कि mortality rate कम है, but morbidity long term क्या होगी we cannot say. ठीक है, तो जहां पे भी आपके यहाँ केसेस आ रहे हैं या जहां पे भी आपके पास है पूल ऑफ केसेस जो MIS करके आए थे, so my suggestion would be कि you keep following them. ठीक है, because we don't know, जैसे कावासाकी के acute outcomes नहीं होते, but coronary artery abnormality और आगे जाके what damage this is going to cause we don't know. जिनको cardiac involvement हुआ था, क्या वो absolutely normal हो गए हैं या आगे जाके उनको residual heart disease रहेगा. So a good effective follow up is the only hope that we have. तो इसलिए we should follow such children. आप discharge के time पे उनको you can explain it to them, and a good follow up is really important so that we know कि कितने cases में residual home है. But अभी as of now the data that we have and the literature that we have received till now अभी तक तो नहीं है, but we hope the same thing continues long as well. So my take home message would be MIS is not so uncommon, I would say, in the current scenario. Think of common conditions. इस talk का मतलब ये नहीं है कि आप हर चीज हर बच्चे में MIS suspect करने लगेंगे. Just think of common conditions. Whether या आपके यहाँ जो भी infection ज्यादा common है, तो पहले उन्हीं को आपको treat करना है. This is sort of You can say diagnosis of exclusion. जब आप सारे अपने common infections को exclude कर देंगे, आपको hint मिल रही है, pallor है, hepatosplenomegaly है, chills and ragas, you will think of malaria. Otherwise, malaria में भी आपको cerebral malaria में CNS मिल सकता है, hepatic involvement मिल सकता है, thrombocytopenia, so वो MIS नहीं है. So the point is कि think of common thing. जो चीज आपको दिख रही है उसको आप पहले सोचिए, but back of mind पे हमेशा ये रखिए कि एक entity है जो हो सकती है. And provide good supportive care, because अभी best part यही है कि ज्यादातर respond कर रहे हैं, the mortality rates have been low, so just provide good care and investigate. जो आपको investigations और antibiotics है judiciously use करना. You can start, but over investigate नहीं करना है, because it will add to your confusion. Outcomes have been favorable, so you just give supportive care and wait and watch. So this is the suggested reading, and I would like to thank all the contributors for their tireless effort in bringing this to the current day, and thank you all. So this is all I have to say about MIS. Any questions? Okay, so over to the organizers. Any questions? Do I see something in the chat box? No, nothing. Okay then. So I would like to invite the next speaker. Over to the organizers. Thank you.
Thank you, Dr. Aisha, for this excellent presentation. And now I invite Dr. Sandhya Chauhan, and she will be taking lecture on general PICU management.
Thank you, ma'am, for inviting me. Good afternoon, ma'am, and good afternoon to all the participants. I'll just share my screen. So, I'm going to talk about the general care of a child in a pediatric intensive care unit, and our learning goals for this session are going to be to learn the importance of the supportive care in pediatric intensive care unit, to learn the components of general care of critically ill child and how to provide that holistic general care. Okay, so okay. Okay, so whenever we admit any patient in pediatric intensive care, ICUs, what is our main goal? Our main goal is basically the early identification, kitni criticality hai, what is the severity of that patient, and resuscitation of that critically sick child or patient. So our primary focus is on the precipitating disorder and what intervention according to that disorder we have to give. But one thing जो हमें कभी नहीं भूलना चाहिए, that intensive care setting in itself, this word itself and the setting itself denotes a very hostile and dangerous environment. So on one hand, we are definitely right in focusing on the primary illness and the severity related to it. On the other hand, we should not forget the basics of routine care in pediatric intensive care unit. Now this routine care, आपने किसी भी disease का patient admit किया हुआ है, suppose you have admitted a patient with ARDS and you have mechanically ventilated that patient, or you have admitted some patient who is suffering with acute kidney injury, या किसी को admit किया जिसमें life threatening MISC है. Primary disease के साथ साथ you have to follow a basic care bundle for that patient, supportive and preventive care for that patient, and this supportive and preventive care is universal, it is uniform, it is standard across each and every pathology. This we have to understand. Okay, next slide. Okay, so once we talk of the supportive care, ये supportive care है क्या? This supportive care has three components. पहला, as the slide is showing, monitoring है, दूसरा प्रिवेंशन ऑफ न्यूज़ोकोमियल इन्फेक्शंस है, और तीसरा ऑनगोइंग असेसमेंट एंड सपोर्ट है. जब हम मॉनिटरिंग की बात करते हैं, दिस मॉनिटरिंग इज ऑफ द एस्पेक्ट्स ऑफ द पेशेंट रिलेटेड टू द प्राइमरी पैथोलॉजी पर से, दैट इज द फिजियोलॉजिकल इंडिसेस क्या है पेशेंट के, आपने जो ट्रीटमेंट दिया है वेदर द पेशेंट इज रिस्पॉन्डिंग टू दैट ट्रीटमेंट और नॉट, अगर इफ द पेशेंट इज नॉट रिस्पॉन्डिंग यू हैव टू इवैल्यूएट द ट्रेंड्स and raise alarms and manage the patient accordingly. This we have already dealt in the previous lectures. A second component है prevention of nosocomial infections. Now there is a basic bundle of maneuvers which is practiced in each and every ICU to prevent nosocomial infections, and hand hygiene is the most important component of this bundle. This we will discuss later. थर्ड है ऑनगोइंग असेसमेंट एंड सपोर्ट. अब इसका क्या मतलब हुआ? तो अपार्ट फ्रॉम द बेसिक डिजीज पैथोलॉजी एंड मॉनिटरिंग इट्स कोर्स, दिस ऑनगोइंग असेसमेंट डील्स विद अदर एस्पेक्ट्स ऑफ पेशेंट केयर which if neglected will not only make the treatment of the basic pathology difficult and complicated but will also make the treatment costly, ICU stay longer, and even add substantially to the mortality of that critically sick patient. अब ये बहुत सारे एस्पेक्ट्स हैं, these are multiple aspects, but it is very easy to remember by this mnemonic which is shown on the slide: fast, hugs, bids. Now what I will suggest is to all the listeners at present, you as my lecture goes on, you prepare a checklist with the help of this mnemonic. Use this checklist on your daily rounds every day, as well as you train your ICU staff, your nursing staff to use this checklist at the start of their every shift to keep a track of the key aspect of the general care of the critically sick patient. We will see one by one what these components are. So in fast, hugs, bids, F stands for feeding, A is analgesia, S is sedation, T is thromboembolic prophylaxis, H is head of bed elevation, U is stress ulcer prevention, G is glucose control, S is spontaneous breathing trial, B is bowel regime, I is indwelling catheter removal, and D is de-escalation of antibiotics. अब इसमें जो spontaneous breathing trial है, this has already been dealt on the lecture on mechanical ventilation, तो ये I won't be discussing here. The rest of the components I'll take one by one and you can just follow with the help of this mnemonic. So starting with feeding. Now several RCTs have shown that early feeding, चाहे आपका patient intensive care में है, this should not go कि once the patient gets stabilized only then I'll start the feeding. No. RCTs have shown that early feeding, it reduces the incidence of morbidity and mortality in ICUs. कैसे? By improving wound healing. बहुत बड़ा role play करते हैं in wound healing. Decreasing the loss due to metabolic stress response that the patient is already undergoing. Improves GI function and integrity. So whatever feeding support that we give to our patient in ICU, it not only helps in improving the nutritional status of the sick patient, but it also helps in reducing the complications and the length of stay in ICU of that patient. अच्छा, अब देना कितना है, how much calories should we give? तो always remember that an acute phase of illness, शुरुआती दिनों में, this is not decided by the recommended daily allowance, that is RDA. RDA से हम नहीं calculate करते हैं caloric goal. It is calculated, it is decided by REE, that is the resting energy expenditure. क्या होता है ये? This is the energy intake what you are providing to that patient should not exceed this resting energy expenditure. अच्छा, how to calculate this REE? So there are a lot of formulas available on online which you can use, but एक छोटी सी चीज़ है that if we just restrict ourselves to a target caloric target between 27 to 58 kilocalories per kg per day, since we are talking of children, तो per kg per day 27 to 58 kilocalories per kg per day के बीच में अगर हम अपने आप को restrict करते हैं उनको energy intake देने में, तो this will provide the energy intake according to REE in that critically sick child. Okay, protein goal हमारा क्या होना चाहिए? It should not exceed 1.5 gram per kg per day. अच्छा, one thing again we have to remember that the caloric requirement increases in cases of fever or burns or sepsis, trauma, activity कुछ हो रही हो तो हमें उसी accordingly बढ़ाना पड़ता है. अच्छा, now what should be the mode? So we have two modes, एक enteral feeding है, दूसरी parenteral feeding है. Enteral feeding, here the GI tract is directly used to deliver the nutrients and calories either orally or through the NG/OG tube. Now this is superior and the preferred one as compared to the parenteral nutrition. Parenteral nutrition में क्या करते हैं? We are delivering the nutrients directly into a vein. So enteral feeding is normally superior and is the preferred one because it is more physiological. अच्छा, it has a good trophic effect on gut mucosa. It helps in preventing bacterial translocation, thereby decreases the incidence of sepsis. is simple, cheap, easy to administer and is associated with very few metabolic complications. इसके अपने disadvantages होते हैं. अगर NG ट्यूब डिस्प्लेसमेंट हो जाए तो रिस्क ऑफ एस्पिरेशन बढ़ जाता है, फीड इंटॉलरेंस हो सकती है पेशेंट को डिपेंडिंग अपॉन किस पैथोलॉजिकल स्टेज से वो गुजर रहा है. But still parenteral, we resort to parenteral nutrition selected only in conditions where enteral feeding is contraindicated. जब तक contraindicated नहीं है हम नहीं यूज़ करेंगे parenteral feeding. अच्छा, contraindications क्या हैं? अगर पेशेंट में GI bleed हो रहा हो, पेशेंट की पैथोलॉजी ऐसी है that is suffering with gut ischemia, और इंटेस्टिनल परफोरेशन का केस आया है हमारे पास, ऑब्स्ट्रक्शन का केस आया, और इन दीज केसेस वील रिजॉर्ट टू पैरेंटल फीडिंग, क्योंकि इसके बहुत सारे डिसएडवांटेजेस हैं. लाइक क्योंकि डायरेक्टली न्यूट्रिएंट को हम वेन में डिलीवर कर रहे हैं, दिस इज नॉन फिजियोलॉजिकल, इट्स एक्सपेंसिव, रिक्वायर्स वीनस एक्सेस, और इसीलिए इंसिडेंस ऑफ सेप्सिस, रिस्क ऑफ सेप्सिस बढ़ जाता है. देयर आर लॉट ऑफ मेटाबॉलिक कॉम्प्लिकेशंस एसोसिएटेड विद इट व्हिच रिक्वायर वेरी फ्रिक्वेंट मॉनिटरिंग. दैट्स व्हाई नॉर्मली इट इज एंटरल फीडिंग व्हिच इज प्रेफर्ड. अच्छा, now we have planned to start the enteral feeding. तो हमें करना क्या है? तो first you assess your patient for the presence of any contraindications to enteral feeding तो नहीं है. देखिए उसमें bowel sounds present है या नहीं है. अगर bowel sounds present है and there are no contraindications present for enteral feeding, you can start the enteral feeds within 24 to 48 hours of the admission of that patient in intensive care unit. Before we start the feeding, every time we have to ensure that the head end of the patient's bed is elevated. Okay. Again, in enteral feeding we have two routes. One is nasogastric feeding, other is post pyloric feeding, where the tube is in the jejunum or in the duodenum. Okay, तो whether we should go ahead with nasogastric या post pyloric कौन सी करनी है, ये इस बात पे डिपेंड करता है कि whether the risk factors for aspiration are present in that patient or not. Suppose the patient is having severe respiratory distress, या patient recurrent vomiting का है, या gastroesophageal reflux है with a history of aspiration, या pathology उसकी ऐसी है which has led to delayed gastric emptying. If these conditions are present, we'll resort to post pyloric feeding, और नहीं है तो we'll go ahead with nasogastric feeding. अच्छा, nasogastric feeding is normally given in the form of bolus feeding. यहाँ पर हम करते क्या है? We start with 25% of the target volume, और इसे हम 2 to 4 hourly interval पे, 2 to 4 hourly basis पे देते हैं. Let's see an example. एक एग्जाम्पल लेते हैं कि सपोज हमारे पास एक 10 kg वेट का बच्चा है in the intensive care unit, और we have decided that in order to fulfill his caloric goals, we will be giving सपोज हमने क्या 500 किलो कैलोरीज उसको देनी है 24 घंटे में, एंड द वॉल्यूम दैट वी डिसाइड टू डिलीवर दिस कैलोरीज इज 500 ml. ठीक है, तो 24 आवर्स में हमने डिसाइड कर लिया, हमने कैलकुलेट कर लिया कि 500 ml हम इसे देते हैं एक पर्टिकुलर फीड, तो उसे उसकी रिक्वायर्ड कैलोरीज REE के हिसाब से मिल जाएगी. अब फर्स्ट वील टेक आउट द 25% ऑफ दिस टारगेट वॉल्यूम. टारगेट वॉल्यूम क्या है? 500 ml 24 घंटे में, इसका 50% निकाला, अमाउंट निकल के आया 120 और 125 ml. नाउ 120 और 125 ml, दिस हैज़ टू बी अगेन डिवाइडेड इनटू वॉल्यूम्स व्हिच कैन बी गिवन. सपोज मैं सोचती हूँ मुझे 4 अर्ली फीडिंग स्टार्ट करनी है. ठीक है, तो 120 ml को 4 अर्ली फीड्स, यानी अगर 4 अर्ली फीड्स दे रहे हैं तो 24 घंटे में हमने दी 6 फीड्स, तो 120 ml डिवाइडेड बाई 6 कितना अमाउंट आया? 20 ml 4 अर्ली. सो वी विल स्टार्ट विथ 20 ml 4 अर्ली. अगर पेशेंट, इफ़ द पेशेंट टॉलरेट्स 2 to 3 सच फीड्स, 2 या 3 फीड्स आपने दी, पेशेंट ने टॉलरेट किया, कोई इंटॉलरेंस नहीं हुई, वी कैन प्लान फॉर फीड एडवांसमेंट. और ये जो इंक्रीज़ करेंगे, जो एडवांसमेंट करेंगे, इट इज़ अगेन डन एट 25% इंक्रीमेंट ओवर द स्टार्ट वॉल्यूम. तो स्टार्ट वॉल्यूम क्या था? 20 ml 4 hourly. इसकी 25% इंक्रीमेंट कर दी तो नेक्स्ट वॉल्यूम वुड कम आउट समवेयर बिटवीन 25 ml 4 hourly, देन 30 ml 4 hourly, देन 35 ml 4 hourly. इस तरह से करके जैसे जैसे पेशेंट टॉलरेट करता चला जाता है, हम 25% इंक्रीमेंट प्रीवियस वॉल्यूम का बढ़ाते चले जाते हैं टिल द टारगेट वॉल्यूम ऑफ 500 ml in 24 hours we reach. अच्छा, इफ़ वी गो अहेड विथ पोस्ट पाइलोरिक फीडिंग, इट इज़ प्रेफरेबली गिवन बाय कंटिन्यूस फीडिंग. जो हम रेट रखते हैं वो 1 to 2 ml पर kg पर आर का रखते हैं. अब यही बच्चा ले लेते हैं जो 10 किलो का है, तो 1 to 2 ml पर kg पर आर क्या हो गया? यानी कि 10 to 20 ml पर आर. मैक्सिमम कितना दे सकते हैं? 25 ml पर आर. तो इतने से हमने स्टार्ट कर लिया. Now again we will go on increasing the target volume every 2 to 8 hourly depending upon the feed tolerance of that patient till हम टारगेट वॉल्यूम को रीच करते हैं. और टारगेट वॉल्यूम क्या है? लेस देन 1 ईयर में 5 ml पर kg पर आर के हिसाब से, और मोर देन 1 ईयर में 5 to 20 ml पर kg पर आर के हिसाब से हम बढ़ सकते हैं. ओके ओके one thing we have to keep in mind is that once we are planning for feed advancement, suppose हमने 8 बजे अपनी फीड दी और 12 बजे की फीड अब मुझे इंक्रीज करके देनी है क्योंकि मेरा पेशेंट टॉलरेट कर रहा है, तो बिफोर गिविंग द फीड एट 12 noon, what I'll do is I'll check for the pre-feed gastric residual volume. NG या OG ट्यूब ऑलरेडी पड़ी हुई है पेशेंट में. बिफोर गिविंग द नेक्स्ट फीड 10 ml syringe I took and I just try to lightly aspirate the residual gastric volume. Suppose मैंने पिछली फीड दी थी 20 ml की और ये जो गैस्ट्रिक रेसिडुअल वॉल्यूम खिंच के आता है ये आता है 15 ml. दैट इज मोर देन हाफ ऑफ द प्रीवियस फीड वॉल्यूम. आई एम नॉट गोइंग टू गिव द नेक्स्ट फीड. आई होल्ड द नेक्स्ट फीड. Again, I'll assess if the patient is not responding. I'll try to give prokinetics, metoclopramide or domperidone in a dose of 0.2 milligram per kg per dose. 8 hourly basis पर हम use कर सकते हैं. Still, if my patient is not tolerating, I can go ahead with smaller volume frequent feeds. यानी 20 ml 4 hourly को 10 ml 2 hourly या 5 ml hourly feeds में हम convert कर सकते हैं. Okay, what should be the composition of the feeds? It should be such as to meet the needs of the critically ill child. So up to 6 months breast milk, express breast milk या formula feed use किया जाता है. 1 to 10 years में milk based feeds use कर सकते हैं. Other feeds like dal and porridge also can be used. You can even fortify the feed with the help of MCT oil or sugar or puffed rice to increase the caloric density. And you can and care has to be taken for the supplementation of vitamins and minerals in recommended daily allowance, either IV or orally. Okay, now once the acute phase of the illness is over, that is by 7th to 10th day of illness, now you will have to increase the caloric delivery to more than 50% from the present value in order to avoid underfeeding and thereby ensuing malnutrition in your patient. Okay, next we'll talk about sedation. As for sedation, once you admit your patients in intensive care unit, आप सोचो आप क्या करते हो वहाँ पर. You will be doing a lot of medical procedures for the patient, frequent invasive testings for the patient. Obviously that is all needed. You are trying to help the patient according to his pathology, so obviously we'll be needing all those things. लेकिन since we are doing all these things, frequent invasive testings कर रहे हैं, procedures कर रहे हैं, this necessitates the provision of adequate analgesia and sedation in the patient in order to not only to decrease the pain but also to decrease the stress response. Always remember, these agents have to be used judiciously, intermittently and with frequent monitoring of patients. क्योंकि जहाँ पर under sedation will lead to stress with long term consequences, over sedation will lead to need for prolonged respiratory support and prolonged ICU stay, and that nobody will ever want. Analgesia and sedation, they are preferred over neuromuscular blockade because they are quickly reversible and allow for neurological monitoring, which is very important in such patients. While selecting the agents that you have to use for sedation and analgesia, use the agents which have minimal effect on the vital parameters, especially the blood pressure. Sedation के लिए आप short acting benzodiazepines like midazolam use कर सकते हैं in a dose of 0.1 milligram per kg bolus, followed by infusion 1 to 10 microgram per kg per minute. 1 microgram per kg per minute से start करके depending upon the level of analgesia sedation that you need, you can go on increasing up to 10 microgram per kg per minute infusion. For analgesia, fentanyl can be used in 1 microgram per kg bolus, followed by 1 to 5 microgram per kg per hour infusion depending upon the need. Pediatric, in pediatric ARDS, again I'll repeat, these agents should be titrated for their maximum desirable effect with minimal possible dose. That is very important. If sedatives are not completely effective, you can use neuromuscular blocking agents like vecuronium in a dose of 0.15 milligram per kg, followed by bolus, followed by 15 to 25 microgram per kg per minute, जैसी requirement है. In moderate to severe ARDS, neuromuscular blocking agents, they improve tolerance to mechanical ventilation by eliminating ventilator patient dysentery, and they also help in optimizing oxygen delivery by facilitating gas exchange, and that is what you want in a patient of ARDS, obviously. So if you are giving neuromuscular blocking agents, you are in turn not only sedating and not only decreasing the response of that patient's stress response, but you are also helping him better cope up with the ventilator process. But again, their use has its own limitation in the form of profound muscle weakness. So again they should be used in minimal possible dose. और एक चीज़ और ध्यान में रखनी है, along with observing a daily neuromuscular blockade holiday of at least 1 hour every day in order to monitor for the patient monitor the patient for clinical movement or development of critical illness polyneuropathy जो इसका side effect है. Okay. Next, glucose control. Now, in critically sick patients, blood glucose abnormality, especially hyperglycemia, is also common in pediatric intensive care. क्यों? Because it is a stress hormone response. पहली चीज़. दूसरी, you'll be using additional medications in your patients in ICUs like steroids, exogenous dextrose administration आप कर रहे होंगे, तो all this will give rise to hyperglycemia. Both the duration of hyperglycemia and the index of variability of glucose levels, especially the peak glucose level, they are independently associated with mortality in intensive care units. Achha. Normally, all the ICUs they follow the protocol of testing the blood glucose level at the time of admission. सब करते हैं हम. If normal, then continuing its monitoring at 12-hourly interval. Any abnormal reading is followed by more frequent monitoring at the rate of 2 to 4-hourly interval. एम क्या है? टू मेंटेन द ब्लड ग्लूकोज लेवल ऑफ लेस देन 150 मिलीग्राम पर डेसीलीटर. इतना तो ठीक है, बट it has to be remembered that aggressive attempts of lowering this blood glucose level or keeping a tighter glucose control can lead to hypoglycemia, which is equally deleterious. तो एम क्या होना चाहिए? Of a moderate glycemic control. Any blood glucose level of more than 180 milligram per deciliter, definitely we will have to intervene. पहला intervention होगा reduction of the glucose infusion rates that you are giving. नहीं respond करता है तो definitely you will go ahead with insulin infusion. Next is pressure source. Common in PICU, incidence is 26%. Common sites are occipital region, nose, chin or neck, heel and sacrum. Risk factors: mechanical ventilation, high frequency oscillation, HFO, hypotension, malnutrition, sensory loss, dependent edema, central line in the neck, length of stay of more than 96 hours. Everything happens in some of the other patient in intensive care units and thereby predisposes to pressure source. कैसे prevent कर सकते हैं? For this, you train your nursing staff for regularly examining the skin, frequently repositioning the patient every 2 to 4 hourly, providing adequate nutrition, keep the sheets dry and wrinkle free, and alternately, as shown in the photograph, you can use pressure mattresses. Okay, before I show you the photographs, this is the classification of the pressure source that we can see is in stage 1, it is intact skin with non-blanchable redness. Management is just protective dressing. Stage 2, where it is shallow open ulcer with red pink wound. Here we can use moist dressing such as transparent film, hydrocolloid dressing, hydrogel, foam, alginate dressing, etc. Clean the wound with saline water and then you apply these moist dressings. Stage 3, full thickness tissue loss with visible subcutaneous fat, and stage 4 is full thickness tissue loss with exposed muscle and bone. Here, if no necrosis is present, then clean the wound and then apply moist to absorbent dressing. In unstageable pressure source, full thickness tissue loss is there and the base of the ulcer is covered with lot of necrotic tissue, slough or eschar. Here first you will have to do the debridement of this necrotic tissue, then you will clean the wound and then you will apply moist absorbent dressing. Achha, there is one condition also where you suspect deep injury. The patient will present to you purple maroon localized area of discolored intact skin or blood filled blister and has to be managed. Okay, so this is the photograph in stage 1. It is non-blanchable erythema of intact skin. Here, stage 2, partial thickness skin loss with exposed yellow dermis. Stage 3, this is full thickness skin loss with exposed subcutaneous fat, this yellow portion. This is stage 4, full thickness skin and tissue loss, and in the center there is the bone visible which is involved, and this is the unstageable where there be full thickness skin and tissue loss, but since there is a lot of necrotic tissue present, so we cannot find out exactly what is the depth of the wound. Okay, next is eye care. Acha. Now just think what all you do to a patient in intensive care unit, patient को benefit पहुँचाने के लिए क्या क्या करते हैं वहाँ पर, like we are giving them oxygen either through mask or through CPAP. Now what this is doing, there are gas flows coming through the oxygen mask या CPAP के through. This has a drying effect on the corneal surface of the eyes. अच्छा, आप sedate कर रहे हो patient को patient के फायदे के लिए, What sedation is doing? It is reducing the blink reflex. You're giving muscle relaxants to the patient. What they are doing? They are decreasing the ability of the patient to close eyes, leading to lag of thalamus. अच्छा, अब इसमें ड्राइंग हो रही है, ब्लिंक रिफ्लेक्स ख़त्म हो रहा है, patient's ability to close the eyes decrease हो रही हैं. What all these mechanisms do for us? The ocular surface of our eye is normally protected by all these abilities. The ability to produce tears, to blink, to close eyes with rest and sleep, ये सब protect करते हैं हमारी eyes को. पेशेंट के फ़ायदे के लिए हमने जो कुछ भी करा, इट इज़ हैविंग अ हैम्परिंग इफेक्ट ऑन दीज मैकेनिज्म्स. Because of this, lot of abnormalities of cornea and conjunctiva they occur in such patients. जैसे एक्सपोजर केरेटाइटिस हो गई, कॉर्नियल अल्सरेशन हो गया, इन्फेक्शन हो गया, ठीक है. एंड दिस इज सीन क्वाइट कॉमनली इन क्वार्टर ऑफ पेशेंट्स इन ICU. क्या कर सकते हैं? Use lubricating ointments, artificial tears to keep the cornea and conjunctiva wet. 1 drop every 6 hourly in both the eyes. If eyes are not fully closed, you can use, as shown here in the photograph, protective eye taping. It's very effective in preventing corneal erosion. In cases of evidence of infection, you can definitely use antibiotic eye drops. Achha, oral hygiene. Again, all the mechanisms and the procedures that we are doing in intensive care unit for the benefit of the patient, वो कैसे compromise करते हैं oral hygiene को? Like a critically ill child, he may not be able to maintain maintain the normal saliva production. क्यों? आपने sedation use किया हुआ है, fluid restriction किया हुआ है, nil orally किया हुआ है, there is nothing going through the oral mucosa. Drugs use किए हैं, that में exacerbate xerostomia. तो you are decreasing thereby the normal saliva production. ये कम हो रहा है तो क्या हो रहा है? Predisposition of the oral cavity to colonization by drug resistant organisms हो रही है और plaque formation हो रहा है. Both of these things, they will form a very important source of ventilator associated pneumonia. Therefore regular cleaning of oral cavity, especially in intubated kids, is very important. कैसे कर सकते हैं? By using antiseptic solutions like chlorhexidine. अच्छा, while cleaning, you'll have to train your nursing staff to ensure that the dislodged plaques and secretions, they are not aspirated. कैसे? By keeping the head end elevated, endotracheal tube cuff inflated at the time of suctioning, using closed suction as far as possible. Okay, NHSGGC has given certain clinical guidelines for maintaining the oral hygiene in intensive care units. They have for the management purpose, they have divided the pediatric patients into 3 groups. First is neonates and infants without any teeth, then infants and children less than 3 years with teeth, and then children more than 3 years with teeth. So before we start managing the oral hygiene, ensure that the head end of the bed is elevated to 30 degrees, wash and dry the hands, don disposable gloves, and you can use any mouth assessment tool available online. Once you start the management, the first we will begin with neonates and infants without teeth. Aim क्या है? To keep the oral mucosa moistened throughout. ठीक है? So every 2 to 4 hourly, how this is done, you wrap a swab moistened with sterile water or saline around your gloved finger, and then wipe the gums and mucosa with the swab to moisten the mouth. Apply yellow soft paraffin to lips. In infants and children with teeth, साथ में क्या करना है? 12 hourly brushing of the teeth with soft small headed toothbrush and smear of fluoride toothpaste has to be done. अच्छा, in the third group, in children more than 3 years with teeth क्या करना है? 2 to 4 hourly moistening तो करनी है, 12 hourly brushing of the teeth भी करनी है, और third चीज़ क्या करनी है? 30 minutes after tooth brushing, apply 1% chlorhexidine gluconate gel to the oral mucosa, teeth and gums. Do not rinse or moisten mouth with water following this. So in this way we can maintain you can teach your nursing staff to maintain the oral hygiene of your patient. Next is stress ulcer prophylaxis. Now, critically sick patients suffering especially with hypoglycemia or decreased cardiac output or intense pro-inflammatory cytokine release, they are usually predisposed to acute gastric ulcers due to decreased mucosal blood flow or decreased GI motility. These ulcers will lead to upper GI bleeding if there is factors like thrombocytopenia, coagulopathy, organ failure, mechanical ventilation and use of high pressures there, shock, prolonged surgery or steroids are being used in the patient. But still, prophylaxis is not routinely advised because RCTs say that it may increase the risk of nosocomial infections. तो आपको क्या करना है? Be cautious, observe for the amount and the color of the nasogastric aspirates. If the amount increases or the color changes from colorless to suppose a reddish or brownish aspirate, this is the indication for a beginning of GI bleeding, and you will have to manage by giving drugs like ranitidine, sucralfate or PPIs or pantoprazole. Next is thromboembolic prophylaxis. Now, venous thromboembolism is increasingly being recognized in children because of the presence of certain risk factors secondary to the illness, primary pathology जिसकी वजह से आए हैं, age less than 1 year या more than 14 years, recent surgery, the child has undergone recent surgery, or he is suffering with complex medical conditions like malignancy या chronic cardiac disease है, chronic renal disease है, prolonged hospitalization है या inherited acquired thrombophilia है. Central venous catheter is the most common risk factor for thromboembolism in pediatric patients. What you have to do is strict monitoring of the clinical signs and symptoms of venous thromboembolism should be done. अच्छा, most pediatric VTs ये catheter related होते हैं, तो they'll be located either in the upper venous system or in the lower. अगर upper venous system में है, this will give rise to swelling, pain, discoloration in the upper extremity. नीचे लगाया हुआ है तो abdominal, inguinal और leg pain हो जाएगा, swelling, bluish purple discoloration in the lower extremity होगा. If suspected, Doppler venous ultrasound is the commonest modality to diagnose this. Again, standard unfractionated heparin या low molecular weight heparin prophylaxis is not routinely advised, but since we are talking of severe COVID-19 and MISC, here it definitely has an indication if your patient has presented with thrombosis, definite evidence है thrombosis का आपके patient में, या D dimer values आपने कराई हैं, it is more than 5 times the upper limit of normal, या the patient has been diagnosed to be having giant aneurysm with absolute coronary diameter of more than 8 millimeter, या coronary aneurysm score has been reported to be more than 10Z score, या लेफ्ट वेंट्रिकुलर इजेक्शन फ्रैक्शन जो है पेशेंट का वो लेस देन 30% है, तो डेफिनेटली यू कैन गो अहेड विथ लो मॉलिक्यूलर वेट हेपेरिन एंड ऑक्सीपेरिन. Still, you will have to, before you start the drug, you will have to look for certain contraindications like marked thrombocytopenia. अगर platelet count 50,000 के नीचे नहीं यूज़ कर सकते, hypofibrinogenemia, fibrinogen activity less than 100 milligram per deciliter है, नहीं यूज़ कर सकते. Patient, your patient is having end stage renal disease or he has suffered with recent major bleeding, you cannot use this drug, so you have to look accordingly. Once you have started, duration of the treatment is until at least 2 weeks after discharge from the hospital. अच्छा, longer outpatient therapeutic enoxaparins use कर सकते हैं if the patient is having an evidence of like coronary aneurysm score more than 10Z score है तो treatment indefinite होता है. Ongoing moderate to severe LV dysfunction है, treatment indefinite होता है. Documented thrombosis अगर है तो more than 3 months pending thrombus resolution, thrombus खत्म होने के 3 महीने बाद तक आप यूज़ करते हो. Dose in neonates it is 2 milligram per kg twice daily subcutaneously. 1 month old में 1.5 milligram per kg twice daily subcutaneously. 2 months to 17 years में 1 milligram per kg twice daily subcutaneously. Remove central venous line associated with VT as soon as possible. Ensure follow-up ultrasounds to screen for extension of VT. VT आपने diagnose कैसे किया था? Ultrasound करवाया था. A single time ultrasound is not enough. You will have to ensure follow-up ultrasounds also to see whether it's responding or it's increasing. Other maneuvers like early mobilization and physiotherapy, use of compression devices like stockings have to be used in your patients. Another drug, aspirin, it also can be used for prophylaxis per se if there is evidence of thrombosis or coronary aneurysm score is more than 2.5Z score. Dose है 3 milligram per kg per day to 5 milligram per kg per day. Duration until normalization of platelet count and confirmed normal coronary arteries at more than 4 weeks after diagnosis. Contraindications इसके भी अगर active bleeding है, significant bleeding risk है patient में या platelet count less than 80,000 per microliter है, you cannot use it. Care of the lines. Once your patient is in ICU, you put in several lines like IV lines, central lines, chest tubes, PD catheters. Now these lines, they form a very important source of nosocomial infections, and therefore it's very essential to observe these lines very carefully. We will start with IV cannula. by your nursing staff, it should be examined at least once per shift for phlebitis. Not only this, once your staff is giving any bolus injection या IV flow rate check कर रहे हैं या solution containers change कर रहे हैं, they have to observe the cannula site. We have a visual infusion phlebitis scale which will provide an objective assessment of the IV sites कि क्या है और किस तरह से हमें उस समय intervene करना है, इस scale के through देखेंगे. So the scale has score 0 where the site appears healthy, no signs of phlebitis, we just observe the cannula. Score 1 है यानी कि one of the following like slight pain or slight redness is present, these are the possible first signs of phlebitis, again we will observe the cannula. Score 2 में यानी 2 of the following है यानी pain plus swelling है at the IV site या pain erythema है, pain plus erythema at the IV site या swelling plus erythema at the IV site, this is the early stage of phlebitis, remove the cannula, change the site. Score 3 में all these 3 are present, this is intermediate stage of phlebitis, remove the cannula, change the site and consider treatment. Treatment क्या है? Limb elevation, use an anti-inflammatory analgesic like ibuprofen and wearing of compression stockings by your patients. Stage 4 में all the signs are evident and extensive, plus साथ में क्या है? Palpable venous cord. This is we can say advanced stage of phlebitis या the beginning of thrombophlebitis. Remove the cannula, change the site. ट्रीटमेंट में जैसे पहले बताया लिम्ब एलिवेशन, एंटी इन्फ्लेमेटरी एनाल्जेसिक यूज़ करना है, कंप्रेशन स्टॉकिंग्स वेयर करवाने हैं, एंड द फोर्थ थिंग दैट यू कैन ऐड इज यू कैन अप्लाई थ्रोम्बोफोब ऑइंटमेंट एट द लोकल साइट. नाउ व्हाट दिस ऑइंटमेंट इज, इट कंटेन्स विंजाइल, निकोटिनेट प्लस हेपेरिन. तो जिस लोकल साइट पे आप लगाएंगे, इट नॉट ओनली डिसॉल्व्स द क्लॉट प्रेजेंट सुपरफिशियली नियर द स्किन बट विल ऑल्सो रिलीव द पेन एंड इन्फ्लेमेशन बाय इंक्रीजिंग द ब्लड फ्लो. स्कोर 5 में ऑल आर एविडेंट एक्सटेंसिव प्लस आपके पेशेंट ने फीवर डेवलप कर लिया, डेवलप पायरेक्सिया. दिस इज द एस्टैब्लिश्ड फेज ऑफ थ्रोम्बोफ्लेबाइटिस, रिमूव द कैनुला, चेंज द साइट एंड दिस इज द इंडिकेशन टू स्टार्ट एंटीबायोटिक्स. Central venous line, it should be monitored regularly for displacement, bleeding, patency, infection or for hematoma formation at that site. Remove as soon as no longer needed. Yeah, your patient develops fever with no obvious foci. Chest drains, they should be assessed periodically for movement of fluid column, amount and nature of drainage, displacement, breath sounds and subcutaneous emphysema. PD catheter, you monitor the patency of the dialysis catheter and flow rate regularly. Remove as early as possible after completion of the dialysis and never forget to send a PD fluid catheter and fluid and catheter for culture. Next is chest physiotherapy. Now, critical illness in itself followed by intubation, mechanical ventilation, supine position of the patient in ICUs. This leads to deleterious effect on the lungs due to decreased cough reflex, decreased mucociliary clearance, sequestration of secretions, decrease in lung compliance. Here chest physiotherapy plays an important role by in restoring lung health by increasing the drainage of secretions, improving ventilation perfusion matching, decreasing the work of breathing and increasing functional residual capacity. And as shown in the photograph, you can practice various positions or इसमें percussion या vibration के through we can perform chest physiotherapy and help the patient. Practice of prone position in the ventilated children. Now this has been seen to increase oxygenation in early stages of ARDS by increasing the functional residual capacity, increase in ventilation perfusion matching, enabling drainage of secretions and improving lymphatic drainage. What are the indications? It can be used in severe ARDS, children with severe COVID, non-intubated children, and its effectiveness is still being investigated in the moderate cases. If you happen to plan to practice this positioning, so there are 6 positions in one cycle. Every position is practiced for 30 minutes to 2 hours on a flat bed. What are these positions? First, it begins by lying in the prone position, then lying on your right side, then sitting up, then lying on the left side, then semi-proning and then proning. Once a cycle of these 6 steps is completed, you can again start the next cycle. So the key messages for this were, we'll have to understand that holistic care, a whole care is needed for a critically ill child. बहुत सारे aspects हैं, याद करना आसान है. By fast hug spit, practice minimal sedation and early extubation to improve the outcome in your patient. Nutritional support is equally important for early recovery. Physiotherapy done regularly, timely, not only prevents sores but also takes care of the lung health. And always follow the dictum, do no harm to that patient. Okay, these are the suggested readings, these are the skills that we have seen. And now the next part of this lecture, that is how to maintain asepsis in pediatric intensive care unit. The learning goals are that the participants we should know what are healthcare associated infections, nosocomial infections hote kya hain. Second, how to maintain strict asepsis in your ward and minimize the common HAIs. Understand the importance of hand hygiene and how to practice the ventilator associated pneumonia bundle, that is VAP bundle. CDC defines any clinical infection, whether it is localized or systemic, that was not present at the time of admission as healthcare associated infection. It is a major cause of mortality and morbidity. यहाँ तक कि 1/3 of the critically ill children getting admitted in ICUs they suffer with this. 3 common होते हैं: bloodstream infections, ventilator associated pneumonia and catheter associated urinary tract infection. Risk कब बढ़ता है? लेस देन 1 ईयर का बच्चा हो, प्रोलॉन्ग स्टे इन ICU, वेरी इंपॉर्टेंट, जितना ज़्यादा रहेगा उतना ज़्यादा ये बढ़ेगा इंसिडेंस. Severity of illness at admission, it definitely determines this. Prolonged use of sedation, use of broad spectrum antibiotics, pre-existing medical condition, use of invasive devices that we frequently use in ICUs, these are the predisposing factors. Can be reduced? Yes, by following a 4-pronged standard precaution. क्या करना है? Use of PPEs, personal protective equipment, safe injection practices practice करनी है, respiratory और cough etiquette follow करना है, और सबसे important है practice hand hygiene. Now this slide is showing you 2 posters. One is of hand wash, other is of hand rub. You can download it from internet and just display it near the hand wash area. For hand washing, there are 11 steps. Has to be practiced for at least 60 seconds. इतना टाइम लगाना है इसे करने में. यूज़ क्या कर सकते हैं? सोप यूज़ कर सकते हैं या कोई भी हैंड वॉश which has chlorhexidine and alcohol. For hand rub, there are 8 steps. At least person has to devote 30 seconds for this, and 0.5% chlorhexidine with 70% ethanol can be used. This is a very interesting concept which endorsed by WHO. They say the 5 moments of hand hygiene. People who have intensive care units or who have been to the intensive care units, everybody knows that before entering the intensive care units, all of us wash our hands, okay, properly. But what WHO endorses is कि once we enter the intensive care unit, suppose हमारा 5-bedded या 10-bedded intensive care unit है, so we are visiting the first bed. Now, once we are visiting the first bed, before the patient contact, you have to wash your hands, or you are going to examine the patient. Before that aseptic task, again you wash your hands. Suppose there was some Euro bag or ICD bag lying over there. After body fluid exposure risk, after you have examined the bag, again you go for hand wash. Once you have left the patient but are now examining the files and the papers of the patient, after the patient contact, you have to wash your hands. And once you are leaving the patient's surroundings to go to the next bed, again you have to wash your hands. So these are the 5 moments that you have to practice at every bed if you are really serious about preventing HAIs in your patients in intensive care unit. PPEs, these are gowns, gloves, masks, clothing or devices donned for safety or protection while performing hazardous patient activity in order to interrupt disease transmission. ध्यान क्या रखना है? Doffing is the one which is really notorious for spreading HAIs. तो doffing बहुत अच्छे से आनी चाहिए. Second is respiratory etiquette or cough hygiene. तो cover one's mouth while coughing. Hand से नहीं करना है, using the upper arm for this. Disposing of tissues once you have coughed, and following hand hygiene practices after touching the respiratory secretions. Safe injection practices में क्या है? जिस एरिया पे लगना है, clean it with alcohol swab. The nurses have to be trained for this, to clean with alcohol swab. Be in a practice of using single dose vials. Be in a practice of using single use needles. We can also display posters and distribute it to the attendants about minimizing visits and other relevant cares, like before entering, remove your slippers and shoes, ornaments, wash the hands, rub your hand before touching anything, don't sit on the bed, don't touch anything in ICU. ये सब attendants को भी सिखानी पड़ेंगी. If you are allowing parents in the intensive care unit, they have to be done with proper adequate PPE. Okay. Another very important aspect is proper disposal of biomedical waste, very important. Disinfection and sterilization of intensive care unit and instrument, सभी intensive care units करती हैं obviously, but the important thing is proper record of it. कब हुआ है, next कब होना है, this is very important. Time to time culture audit of admitted patients. Send culture not only from the patient and their surroundings but also from the walls of the ICU, ceilings, suction pipe, other areas during regular surveillance, and as far as possible rationally use the antibiotics that you have in hand. How to prevent bloodstream infections? By using central lines made of Teflon and polyurethane, using minimum number of ports. Insertion has to be done under aseptic precautions, जिसमें करना क्या है, scrub up to elbow, use of universal precautions, drapes over the patient, perform skin antisepsis with 2% chlorhexidine or 10% povidone iodine. Use sterile gauze or transparent semi-permeable dressing. Antiseptic ointment should never be used at the site of insertion. Be in a habit of changing the IV fluid administration sets every 72 to 96 hours. Be in a habit of changing the disposable pressure transducers for CVP or ABG monitoring every 72 to 96 hours. How can you prevent UTI? By placing the catheter aseptically. It should not be placed without any indication. Closed drainage system should be used. If contaminated, replace it. Catheter should not be irrigated unless absolutely necessary. Proper hand hygiene and aseptic precautions must be used when handling the catheter. Junction between the catheter and the drainage system should be secured properly, and it should be removed. The catheter should be removed as soon as possible. The last aspect is of ventilator associated pneumonia. Now, this is new onset of pneumonia after 48 hours of mechanical ventilation. It is the second most common cause of healthcare associated infection. Incidence ranges from 20 to 36%. It is associated with high mortality, morbidity, increased length of ICU stay or hospital stay, excessive antibiotic usage, thereby leading to antibiotic resistance. Endotracheal intubation is the most important risk factor, and it increases the risk of VAP by around 6 to 20%. 6 to 20 fold, in fact, not percent. What are the etiological factors? Hospital acquired pathogens, Acinetobacter species, Pseudomonas aeruginosa, Klebsiella species, E. coli, methicillin resistant Staph aureus are the commonest organisms responsible for it. How can you prevent it? Two-prong approach. General measures are follow kariye to prevent HAIs, and then the specific measures to prevent VAP, which is covered under VAP bundle. 6 components होते हैं इसके. I'll take one by one. The first component is to prevent iatrogenic spread of infection. कैसे कर सकते हैं? Adherence to good hand hygiene practices, I've already told. Use of universal precautions. Use of appropriate isolation techniques based on infectious organisms that you have proven or suspected. Second क्या है? To prevent aspiration of gastric contents. Keep the head end of the bed elevated to 30 to 45 degrees. Monitor or drain the gastric contents and avoid gastric distension. Third क्या है? Improve oral hygiene. That also I've already covered. Oral rinsing and cleaning with chlorhexidine. Use of toothbrush and oral swabs in daily oral care, and rest that I've already told. चौथा क्या है? To decrease endotracheal tube risk factors. कैसे कर सकते हैं? Use of inline suction equipment where appropriate and available. Suction of the hypopharynx prior to ET suctioning and repositioning. Maintaining endotracheal tube cuff pressure at the time of all these suctionings. Avoid unplanned extubation and reintubation. अच्छा, पांचवा क्या है? To avoid contamination of the respiratory equipment. वो कैसे कर सकते हैं? Dedicated oropharyngeal suction equipment. एक patient के लिए डेडिकेट करके एक यूज़ करना है. प्रिवेंशन ऑफ अक्यूमुलेशन ऑफ रेस्पिरेटरी सर्किट कॉन्डेंसेट. आपने वेंटिलेटर पे डाल रखा है जो उसका रेस्पिरेटरी सर्किट है. कोई भी कॉन्डेंसेट इकट्ठा होता है अक्यूमुलेट नहीं होने देना, अगर है तो हटाना है. प्रिवेंशन ऑफ कंटामिनेशन ऑफ द वेंटिलेशन इक्विपमेंट. चेंज ऑफ सर्किट्स व्हेन विजिबली सॉइल्ड और malfunctioning, and use only sterile fluids for in humidifiers and for nebulization purpose. Sixth क्या है? To decrease the duration of mechanical ventilation. कैसे कर सकते हैं? Every day be in a habit of practicing neuromuscular blockade holiday for at least 1 hour. Minimal sedation practice करना है. Daily assessment of readiness to extubate. रोज़ एक बार ज़रूर देखना है whether my patient is ready for extubation or not. Appropriate levels of sedation should be maintained such that ideally the child is awake but comfortable. Over sedation अगर आप करोगे it will lead to weaning failure. Continuous heavy sedation should be avoided as this depresses cough reflex and spontaneous ventilation, and it predisposes to the aspiration of oropharyngeal contents, the secretions. So the take home message is, we have to understand the importance of hand hygiene, understand and practice the measures for prevention of common HAIs, and practice swab bundle. These are the suggested references, and my sincere thanks to all the contributors for this presentation. Thank you. That was all. Over to organizers.
For this excellent presentation.
Thank you, ma'am.
And I think there is no question related to your talk. So we move to the last talk of the day. And some participants are trying for the post test right now. So they are not supposed to try for the post test at present. Post test link will be activated after completion of all the sessions. So for the last talk, I invite Dr. Vineet. Dr. Vineet is assistant professor at GSPM Kanpur, and he will be taking lecture on handling of the disease.
Thank you, ma'am. Okay, good afternoon to all. In this last topic of COVID training, we will be going to discuss the management of the disease. It includes the transfer of the dead body from isolation room or ICU to the mortuary, or for the cremation or for the burial. Death is almost always associated with a state of disturbance and confusion or uncertainty among the relative, and it must be very sensitively handled. As we all know that as per study, COVID-19 third wave is supposed to affect the pediatric age group more. We are total 3.31 crores of lab confirmed cases in our country, and around 4.4 lakhs of reported death due to COVID. The main learning scope of our this topic is to shorten the knowledge gap on how to dispose of the dead body of a suspected or the confirmed case of COVID-19 patient. So how can we do this? We can do this by training all the staff, those are identified to handle the dead body in the isolation area or mortuary, ambulance, and those workers in the crematorium and the burial ground for the infection prevention and control practices. And one thing we should know that main driver of transmission of COVID-19 is through droplets, and there is an unlikely to be an increased risk of COVID-19 infection from a dead body to a health worker or a family member who will follow the standard precaution while handling the dead body. Only the lungs of the dead COVID patient, if handled during an autopsy, can be infectious. So, a skill which has to be enhanced. First is the hand hygiene. Second is the proper use of personal protective equipment. And third one is the appropriate disinfection of all the environmental surfaces. So the standard precaution that should be followed by a healthcare worker by handling the dead body, as we already discussed, first is the hand hygiene, second is the use of personal protective equipment. Third is the safe handling of all these sharp objects. Fourth is the disinfect the bag that housing the dead body and instrument and devices that were used on that patient. Disinfect all the linen and all the environmental surfaces. So first is the removal of the dead body from the isolation room or from the intensive care unit. The first is the health worker attending to the dead body should perform the hand hygiene and ensure the proper use of personal protective equipment, that is the water resistant apron, goggles, and 95 masks and gloves. All the tubes, drain, and catheters should be removed, and any puncture, hole, or wound that would resulted from the removal of the catheter or any drain tube should be disinfected with 70% alcohol or 1% sodium hypochlorite solution, and then it should be dredged with some impermeable material to prevent any leakage of the body fluid into the environmental surfaces. All the sharps such as intravenous catheters should be cautiously handled, and they should be disposed of in a sharp container. Plug the all oral and nasal orifices of the dead body to prevent any leakage of the body fluid. And if family wishes to view the body at the time of removal from the isolation room or area, they may be allowed, but with following the standard precautions. Now, place the dead body in a leak-proof zipped plastic body bag along with the identification tag of the patient, which is marked as COVID-19 positive, before being transported from the isolation room or intensive care area to avoid any leakage. Then the exterior of the body bag, it should also be decontaminated with 1% sodium hypochlorite solution, and then body should either handed over to the relative or taken to the mortuary as soon as possible. And all the used soiled linen should be handled with standard precaution and disposed of in a biohazard bag. And all the used equipment should be autoclaved or decontaminated with a disinfectant solution in accordance with the established infection prevention control practices. And all the medical waste must be handled and disposed of in accordance with the biomedical waste management rules of the hospital. And the health staff who handle the dead body should remove the personal protective equipment and perform the hand hygiene. In the end, counseling of the family member, if needed, could be done, and sentiments should be respected. Now coming to the environmental cleaning. Environmental cleaning here means that all the surfaces that were earlier in contact with the patient, that include the floor, bed, railing, side table, IV stand, and it should be wiped with 1% sodium hypochlorite solution. First, it should be wiped with 1% sodium hypochlorite solution and allow at least 30 minutes of contact time, and then it should be provided with air drying. Now, handling of the dead body in the mortuary. All the mortuary staff handling the COVID dead bodies should observe the standard precautions before handling the dead body, and dead bodies should be stored in cold chamber maintained at approximately 4 degrees Celsius. Environmental surfaces, instrument, and transport trolleys should be properly disinfected with 1% sodium hypochlorite solution, and after removing the body, the chamber door, handle, and floor should be cleaned with sodium hypochlorite 1% solution. The mortuary must be kept clean. Sorry for the delay. Now coming to the embalming. One thing we should know that embalming of the dead body should not be allowed. But if there is some unavoidable circumstances, then it must be done, but with the following minimum invasive technique. It should also be avoided, but if there is some unavoidable circumstances, then it should be done with following infection prevention and control practices. The team should be well trained in infection prevention and control practices. The number of forensic experts and support staff in the autopsy room should be limited. The team should use the full complement of personal protective equipment, and negative pressure to be maintained in mortuary. The round-ended scissors should be used. PM40 or any other heavy-duty blade with blunted point to be used to reduce the prick injury. Only one body cavity at a time should be dissected. An unfixed organ must be held firm on the table and sliced with a sponge, and care should be taken to protect the hand. An oscillator saw with suction extraction of the bone aerosol into a removable chamber should be used for sewing the skull. Otherwise, a hand saw with chainmail gloves may be used. Needle should not be reseated after the fluid sampling, and needle and syringe should be placed in a sharp packet after use. Reduce the aerosol generation as much as possible during autopsy using appropriate technique, especially while handling the lung tissue. And after the procedure, bodies should be disinfected with 1% sodium hypochlorite solution and then placed in a body bag. And again, the exterior of which will be decontaminated with 1% sodium hypochlorite solution. The body thereafter can be handed over to the relative and autopsy table to be disinfected as per standard protocol. Transportation, the body secured in a body bag, exterior which is decontaminated already. Now it will pose no additional risk to the staff that transport the dead body. The staff handling the body may follow the standard precaution, and vehicle after transfer of the body to the cremation or burial will be decontaminated with 1% sodium hypochlorite solution. Now, at the crematorium or the burial ground, the crematorium burial grounds staff should be sensitized that COVID-19 does not pose any additional risk to get infected. The staff will practice the standard precaution of the hand hygiene and use of mask and gloves. Viewing of the dead body by unzipping the face end of the body bag by the staff using standard precaution may be allowed for the relative to see the body for one last time. Religious rituals such as reading from the religious script, holy water, and any other last rite that does not require touching of the body can be allowed. But bathing, kissing, hugging, etc. of the dead bodies should not be allowed at any cost. Large gathering at the crematorium or the burial ground should be avoided as a social distancing measure, and it is may possible that close family contact may be symptomatic and of shedding the virus at that time. Electric or the gas crematorium is the best one as it eliminates the chance of infection. The funeral, burial staff and family members should perform the hand hygiene after the cremation or burial. Cremation is recommended either by the electric or gas crematorium or burial depending upon the religious sentiment. Burial should be done in a thick airtight coffin placed at a depth of at least 4 to 6 feet below the ground. An area above and adjacent to the grave must be cemented and marked immediately as an additional precautionary measure. The ash does not pose any risk and can be collected to perform the last rite. I have collected my data from the following references. Anyone interested can go through these links for further study. Thank you, ma'am. Thanks to our contributor. Thank you, ma'am.
Thank you, Dr. Vinny, for this nice talk. And I think no question related to your talk, so thank you. So this was the last talk of this training program, and I hope that this training program will be helpful to our participants. So with this, we come to the end of today's session and of this training program. So before we start the post-test, I want to express my thanks to our DGME sir, Dr. NC Prajapati sir, and our HOD, Dr. Shaili Avasti ma'am. They have given constant support for this training course, and they initiated this training program. Dr. Shaili took a special interest in deciding the academic part of this training program. So I thank them. I thank Dr. Suyog and Mr. Neeraj and his Mamta team for this excellent technical support I received for this training course. So they have worked very hard throughout the last 3 months, and daily we are conducting some training, and they are sending so many links and conducting pre-test, post-test daily. So I thank them, and my sincere thanks to all the speakers. So despite their busy schedule, they are all busy with the PICU management. We are creating more beds for the coming COVID wave. So they are busy with the in-house training, with the PICU development, and still they are taking lectures back to back for last 3 months. So I sincerely thank all the speakers who participated in this training program. So there is some query from the participants about providing the slides. of this training course. So slides and PPTs along with your e-certificate, you will get a link for the PPTs, and by that link you can access all the PPTs of this training course. And I thank all the participants, and because of all of you, this training course was successful, and thanks for your active participation. So now we move to the post test, and before the post test link is activated, I request Mr. Neeraj to brief you about the post test, and thank you all for participating in this training course. Thank you very much.
Thank you, ma'am. Thank you all. Thank you all. This is basically a sample of message what you all have received today. This contains basically 3 links. First is of Zoom. Second link is of YouTube, and the third link basically at the bottom of your message. You can see this link is of post test. You have to use this link to submit your post test, and before that you all have to save this number if you have not saved it, the number from which you are receiving these WhatsApp, as after saving only you can see these links on blue color, or you can use it, otherwise it will be seen as a normal text and can't be used to submit the post test. I'm also showing you how it looks on WhatsApp. You can see this was the message basically which is shared with you today, and the link is not complete. You have to first click on this read more. After that only you have to click on this link. If you will not click on the read more, then you are unable to get the pre-filled form. When you click on this link, the form will come pre-filled, basically your general details like your name, your mobile number, your email ID, and your participant ID. So if you are not getting your participant ID pre-filled, you have to close the particular tab or browser, and you have to click on this link again from your WhatsApp. And after submission, e-certificate will be shared on your WhatsApp today. And if you have any issue, you are facing any problem submitting the WhatsApp, submitting the post test, you can WhatsApp on the number from which you are receiving this links. So I am activating the link. Just wait. You have to click on the link. After it's get activated, I will inform after. Post test link is activated. It will be active for 20 minutes. I request you all to please submit your post test.
Mr. Neeraj? So many participants are asking for the participant ID.
Okay, if you are not getting your participant ID, this means you have clicked on this link before it's get activated. You have to close your browser, your tab, and you have to click on the link again from the WhatsApp. And before clicking, you have to open the complete message in the WhatsApp by clicking on read more. And if still you are not getting what the process I am saying, you can just WhatsApp me. I'll share link with you again. Thank you all. Those who have submitted their posters, they'll receive their e-certificate on WhatsApp today. Thank you. Priyanka, please close the meeting. Priyanka, please close the meeting.